Today we're going to talk, I was of course planning on a half-day lecture, but I want to show you new instrument designs and metallurgy that will give us significant advancements in nickel titanium instruments in the near future. Now there is one reason that root canals fail, and only one reason, and that's the presence of bacteria. So all of our, everything that we do in endodontics is designed to lower the number of bacteria in the root canal system or eliminate them. And one of the things that we have not done very well is the irrigation of the root canal system to remove the tissue. Because if you don't remove the tissue, you can't sterilize, you can't kill the bacteria. And I'm going to show you some, I'm going to demonstrate some new metals, I'm going to illustrate some new instrument designs, and I'm going to show you some videotape of a new irrigation technique as it's working in very complicated root canal systems. But we're going to start off this morning with making educated choices. Endodontics is one of those disciplines of dentistry where there are many thought processes and controversies as to what technique to use or what medication to use, and everyone espouses the particular one when in fact advancements are very slow and new medications, new techniques are very slow to be adopted. What disease has killed more sailors than all the wars combined? And of course I punched the wrong button, so you already saw the answer, and the answer is scurvy. I want to talk to you about this for a minute because this is very representative of what we still see in medicine and in particular in dentistry at this point. In 1601, a young physician by the name of James Lancaster, who was an ensign in the Royal Navy, went on a cruise of a flotilla of 4 ships from England to India. And he thought that perhaps citrus fruit would stop scurvy from occurring. And so on the ship that he was on, every day he gave the sailors 3 teaspoons of lemon juice. And on the other 3 ships, the sailors received nothing. Halfway through the cruise, he had to stop this experiment because 110 of the 278 sailors on the other 3 ships died of scurvy. And he had to take sailors off of his ship and put them on the other ships. He informed the Admiralty about this, how it stopped scurvy. Nothing happened. In 1747, Dr. James Lind performed a very similar experiment and had very similar results in stopping scurvy with citrus fruit. In 1795, the Royal Navy adopted the use of citrus fruit to stop scurvy. And in 1865, the Merchant Marine of England adopted using citrus fruit to stop scurvy. 264 years elapsed between finding the cure for scurvy and implementing the process of stopping it. 264 years. I am only 62 years old, and I say only because when I look around the people here, I am obviously the oldest person in this room. So I still consider myself young. You look like my grandchildren. You look so young to me. But I get aggravated when new materials come along that are obviously superior to older techniques or older materials, and they're not immediately adopted. And they're not adopted because the people who like the old way find something to say about the new technique that is denigrating. I want to read you something that I read from a scientific article just last week, and it was about nickel titanium instruments. How many in here use nickel titanium instruments? Raise your hands. Okay, it's very prevalent in the U.S. And you will still see some articles that cast some doubt on it, but very few. This particular article was rather neutral. I think the findings were positive for nickel titanium, but during the discussion, right after the author said something positive about nickel titanium, he said, however, the major disadvantages of these instruments are their high degree of fragility, absence of elastic memory, lack of fatigue resistance, and accumulation of unquantifiable stresses. Now, I don't know what he's talking about because they're not very fragile. They have wonderful memory. They have extreme resistance to fatigue, separation, and accumulation of unquantifiable stresses. For a moment, I thought he was talking about my personal life, not about nickel titanium. Because when I look in the mirror, I see these unquantifiable stresses that have built up through the years. But this is just denigrating a product or a material without really showing any science. But it's in a scientific article, and I'm sure somebody will quote this if they don't like nickel titanium. Technology, biology, and endodontic success. We're all striving for endodontic success. I don't like to group people into categories, but I'm going to. Academicians generally rely on science, generally are a little more conservative. Clinicians are a little more open-minded and tend to experiment a little more, adopt things a little earlier. So there is this friction. And educators tend to talk about biology, and clinicians tend to talk about new technology, as if new technology is everything. It's not everything. But there are ongoing tensions within our specialty. The biological principles versus clinical convenience. In other words, can you do one-visit root canals? I know that you can, but is it actually better or as good as two-visit root canals? Can we kill more bacteria in 2 visits than in 1 visit? Evidence-based practice, what you experience in your clinic and in dental schools versus product promotion. There's a lot of criticism of advertisements not being scientific. Advertisements are not supposed to be scientific. Advertisements are to get your attention so that you will call a salesperson and hopefully buy the product. There is nothing educational about advertising. And then it gets down to biology versus technology. And of course, the biological basis of endodontic treatment is microbial infection of the root canal space leads to periapical inflammation, which leads to a periapical radiolucency. Healing results from the elimination or prevention of the infection. Simply stated, you want to prevent or you want to eliminate periradicular infection. This is a lower molar, first molar, and it's obviously large canals. Hopefully you can see that. Large radiolucency. And when I did this tooth, this was obviously a young patient because the second molar has not even erupted yet. So this patient is between 6 and probably 10 or 11. I went in, cleaned and shaped the root canal to the best of my ability, and placed medication inside the root canal and put temporary filling on the tooth. And I told the patient, don't bite down on this tooth until we finish the root canal. Don't chew on the tooth until we finish the root canal. And the patient followed my instructions because she didn't come back in for about 3 years. And when she came back in for another tooth that was hurting her. And I looked at the chart and I noticed that I had never finished this root canal, so I took a photograph. I took an x-ray of the tooth. And when I took the x-ray, you can see that the periapical area has completely healed. In fact, the apices have formed on the tooth. This is my apical seal. This is the only seal. So I told the mother that before we take care of this new tooth that's hurting her, we first have to finish this root canal. And she asked why. And I said, because you never paid me for it. So before I start a new tooth, we're going to finish this one and you're going to pay me. And so I finished the root canal. But for 3 years, there was no root canal filling in the tooth. This points out that your cleaning and shaping procedures is what eliminates the majority of the bacteria and the tissue within the root canal system. This creates the healthy environment that allows the periapical tissue to heal. The obturation, or the root canal filling, merely maintains that healthy environment that you've created. Now, during the decade of the 80s, most of the endodontic speakers talked about obturating the root canal. Seal the portals of exit and it will heal, is what I heard over and over. But I'm going to tell you that elimination of bacteria produces endodontic success, and that's the main thing, and obturation merely maintains that healthy environment. The aim of endodontic treatment is to eliminate or prevent infection of the canal space. And here you can see a bicuspid, bayonet shape, apical radiolucency. And here it is obturated. And you can see excess sealer coming out of this accessory canal and here in periapical. And maybe you don't like excess filling material. Most articles that are written about it consider it a detriment to healing. But elimination is the main thing, and it will heal. And my contention is that technology must serve the biological goals of endodontic practice, and technology is able to serve the biological goals of endodontic practice. Why would you develop a technology that is contrary to the biological goals? That would make no sense, and I think no one would purchase it. Now, these controversies in one-visit or two-visit endodontics generally center around the ability of killing bacteria and sterilizing the root canal. And this is an article that was published in 2002, Microbial Basis for Endodontic Treatment. Can a maximal outcome be achieved in one visit? And their conclusion was, until further evidence is available as to the significance of extra-radicular infections, it seems reasonable to view the organisms located within the confines of the root canal space as the main target for treatment. Well, they didn't say one visit or two visit. If you can kill the organisms inside the root canal, why not do it in one visit? Now, Messer, who is an Australian, back in the early 80s, we were using CMCP, and he brought out the effectiveness of CMCP wasn't that good, that we had rapid loss of medicaments in both extracted teeth and clinical cases. And this is what we were routinely using for inter-appointment medicaments. And shortly after that, Bystrom showed that calcium hydroxide sealed in the pulp chamber or in the canals of a tooth inter-appointment produced sterile or bacterial-free canals in 34 of 35 canals tested after a duration of 4 weeks. So most of the clinicians abandoned CMCP and went to using calcium hydroxide as an intracanal medicament. And this may be what you were taught. But Sjogren showed that 7-day dressing with calcium hydroxide eliminated bacteria that survived instrumentation, but a very short period of time, like 10 minutes in a canal, was not effective. So you couldn't use this to sterilize the root canal for a one-visit procedure. It had to be in the tooth for an extended period of time. Now, that's one thought process that says, yes, this is good. Not all scientific articles reach the same conclusion. And here are some studies. The effects of extensive apical reaming and calcium hydroxide dressings on bacterial infection during treatment of apical periodontitis. You know, long studies. I don't want to get into them in detail, but there are other studies that showed that you don't have this high degree of killing of bacteria with calcium hydroxide. There is another position that is present there. And this particular article, you could prove almost anything you wanted to prove with it. And I will talk about it extensively later today. Now, calcium hydroxide that is inefficient against bacteria. These are the specific articles that showed that even after using calcium hydroxide, you had 26% of the cases that still had culturable bacteria. And Ostovic showed that you had 35% of the cases that still had culturable bacteria. Now, after you do the best job of cleaning and shaping and irrigation that you can do, you have sterilized about 2/3 of the root canals if you've done a good job. 1/3 still has bacteria. So you can see here, you might as well not have put any medication in it. And of course, the last one showed the number of positive canals increased. So calcium hydroxide is not the magic cure that we think it is. And literature clearly shows that. Which brings up the possibility, are you being more effective if you fill the root canals in one visit than if you didn't? And in fact, most of the success rate studies show that you are more successful if you have sterile canals, but there are some that disagree with that. Here is two experienced endodontists, and this study was published in the year 2000. Calcium hydroxide inter-appointment for 7 to 22 days versus instrumentation and filling in one visit. And they found there was no difference in the success rate, whether you did it in one visit or intracanal medicaments with calcium hydroxide for a period of time. So this is a randomized clinical trial, and the authors reported residual microorganisms in 29% of the one-visit teeth and in 36% of the two-visit teeth. So there was no statistical difference whether you do it one visit or two visit as far as sterility of the root canal. Now, what I'm trying to show you, how many in here do root canals in one visit? Raise your hand. How many prefer to do two-visit root canals? Raise your hand. Okay, I was taught I'm old enough that I was taught to do root canals in 4 visits. And I was, then we moved to 3 visits. And then I thought I was being very aggressive going to 2 visits. I've been doing 1 visit root canals now for about 15 years. So what you're taught, that these medications are very effective and kill bacteria, is countered by other research that says, no, it's not that effective. I always wondered why. Why can't science agree? Because humans are fallible. And not all teeth are the same. Some teeth are very simple root canal systems. Not many, but some are. Others are very complicated. And we know that if you put these medicaments into a Dappen dish or a Petri dish, all of these medicaments that we use will kill bacteria very efficiently. Sodium hypochlorite will dissolve spores in 45 seconds. So very efficient killing machines for bacteria. So why don't they work inside the tooth? Well, Dr. Hapasalo is one of the most brilliant men that I've ever met that has a personality. I've met many intelligent people, but they generally look to the ground, won't look you in the eye. They couldn't tell a joke if they had to. He's smart and he's intelligent and he has a personality. I like talking with this man. And bacteriology is his area of expertise, and admittedly not my area of expertise. I want to show you what happens inside a tooth with some of these medications. Calcium hydroxide in water kills Ephecalis, and Ephecalis is the probably most difficult bacteria to kill. And CFU is colony forming units. So you'll see that 1 hour of calcium hydroxide in water virtually sterilizes whatever is in contact with. But if you put calcium hydroxide into a tooth, now a tooth, of course, the canals are dentin. And the dentin is composed of basically 2 or 3 things. Hydroxyapatite, which is the inorganic component, serum albumin, which is the organic component, along with water. Water, of course, doesn't hurt it. But you'll notice calcium hydroxide is deactivated by both dentin, hydroxyapatite, and serum albumin. So when you're putting it into a tooth to kill bacteria, its effectiveness is lost because it is inactivated by dentin or its components. Chlorhexidine, which a lot of people talk about as use as an irrigant or intracanal medicament. Chlorhexidine in water works fine. Chlorhexidine with hydroxyapatite delays the effectiveness of it a little bit, but you can see in the same time frame is still very efficient. With dentin, it takes longer to initiate, so there's some effect, but then it is very effective. But serum albumin totally deactivates chlorhexidine. Now, why is this important? Because you would find a lot of serum albumin in pulp tissue that is not removed. And we know that canals have accessory canals, you have isthmuses in between canals, lots of tissue is left, particularly in your complicated molar root canals. And that tissue alone can neutralize chlorhexidine. Iodide, potassium iodide is something that I used to like very much for sterilizing the root canal. Why? Because an article said so. In water, it's very effective. Hydroxyapatite doesn't delay it. Serum albumin doesn't affect it much, but dentin totally deactivates it. So these are reasons that you get these conflicting reports in literature, and these are things that you need to understand about these medicaments. Now, Seltzer and Bender were two great educators up in Philadelphia, and they wrote a lot of scientific articles. I will tell you that neither one of them were wonderful clinicians, but histologists and bacteriologists, they were excellent at that. And they had this theory of cognitive dissonance. This means that there's a disconnect between what we're thinking and what we're doing. And the belief is that thorough debridement of the root canal system, along with sterilization of the system and obturation, would lead to complete success in endodontics. I agree with that. The dissonant part of it is we cannot accomplish that, but you have to do the best you can do. And of course we know that there are fallibilities in the culturing techniques, and can microorganisms actually be eliminated from infected canals? And they said, we seriously doubt that the achievement of sterility is possible, but you want to get it as good as possible, as disinfected as possible. This is a quote from Dr. Kells in 1887. I believe that dentists all over the country are filling at one sitting pulpless roots, roots in all stages of inflammation, as well as those in which the pulps are wholly or partially alive, and not only filling them, but doing so successfully. Any root may be cleaned as well in one sitting as in a dozen. Now, this is a quotation from over 100 years ago. So this controversy of whether we do root canals in one visit or two visits may well go on as long as the controversy about how to eliminate scurvy. It may be with us forever. I hope not, because it isn't too difficult to reach a good conclusion. Now, the reason academicians don't want to advocate one-visit root canals is to do that. They think there's a risk for even more sloppy, not so good endodontics if one appointment becomes the standard of care. So they're very much against it becoming the standard of care. There are some medications that can disinfect the root canal very quickly. This is one. It's marketed under the brand name of BioPure. Most of the endodontists refer to it as MTAD, which stands for a mixture of tetracycline, acid, and a detergent to lower the surface tension so it will enter the dental tubules. The tetracycline is doxycycline, the acid is citric acid, and you mix this all up, insert it into a root canal, and it does several good things. Here was one of the first articles written on it, a new solution for the removal of smear layer. And it was actually designed to use as a disinfecting agent, but along with it, it sterilizes it. In this study, we compared it to several different things. This is water that's being used as an irrigant during the root canal procedure with a final rinse of water. It doesn't work in the coronal area, it doesn't work in the mid-root area, and it doesn't work in the apical area for removing smear layer. This is sodium hypochlorite used during instrumentation, and sodium hypochlorite is a final rinse. Sodium hypochlorite is a wonderful irrigant. I use it all the time. But you can see coronally, mid-root, or apically, it does not remove the smear layer. Here's sodium hypochlorite used as an irrigant, and then a final rinse of EDTA, and you can see smear layer is gone coronally, it's gone in the mid-root area, and apically, most of it is gone. There's still some left in the dental tubules. The negative of this is you can see the architecture of the dentin is eroded somewhat. So the EDTA has been very unkind to this collagen between the dental tubules. In this study, they left the EDTA in there for 3 to 5 minutes. You should never leave EDTA in a root canal longer than 45 seconds to 1 minute. At that time, irrigate it out. Otherwise, you will start seeing this erosion of dentin. Sodium hypochlorite used during instrumentation followed by an irrigation of MTAD. You can see coronally is very clean with no erosion amongst the dentinal tubules. Mid-root is very clean, and even apically, almost all of the smear layer is removed and only a very small amount remaining in dentinal tubules. So this material is very good for removing smear layer. What about killing bacteria? And in this study, they instrumented teeth and sterilized them, and then came back and contaminated them with bacteria from saliva, and then irrigated with MTAD, and they only found one sample that had culturable bacteria. Sodium hypochlorite, a third of them still had culturable bacteria. So this goes right along with what we know from literature. So very effective at killing bacteria. How does it work in killing E. faecalis? Well, killing E. faecalis in 15 samples, it killed the bacteria in every sample. Whereas with sodium hypochlorite, you can see that a third of these routinely still had culturable bacteria. So it's very effective at killing E. faecalis. This is telling you that using this material will allow you to remove the smear layer and kill the bacteria within the root canal system pretty much 98–99% of the time. And knowing that, why continue to do 2-visit root canals? That's the question I ask. And the reason is these medicaments can only work when the tissue is removed. Because if the tissue is not removed, there's still bacteria inside this tissue that the medications can't reach. And there's bacteria in the dentinal tubules that the medicaments cannot reach unless the tissue is removed. All of these studies were done on extracted teeth that were well cleaned, well sterilized, so before the bacteria were introduced. So it's not really equivalent to what you're doing clinically. If I ask you what's the perfect indication for doing a 1-visit root canal, at least 95% of you would tell me a vital pulp exposure, a tooth that is vital. You would prefer to do in 1 visit. You think that's the perfect indication. And I'm going to tell you as a scientist, yes, I agree, because there's no bacteria present there except in that very coronal portion that was exposed during your procedure or the accident. And if you use aseptic techniques like using a rubber dam and sodium hypochlorite, your bacterial control is very good and your success rate should be very high. But I will tell you clinically, I don't do these teeth in 1 visit because you don't go in with a scalpel and sever the pulp at the apex. You go in with a broach and you rip the pulp out of the tooth, tearing it at the apex. There is tissue left in the accessory or lateral canals. And you don't stop there. You irrigate the root canal system with very caustic materials like sodium hypochlorite, and you take these files and you pump up and down inside the root canal, causing inflammation in the periapical area where you severed the pulp, and in the accessory canals where you tore the pulp away from that area. And then you seal the root canal with gutta percha and sealer. Sealer not only is inflammatory producing, some of them are actually toxic that will kill tissue. And you do this all in one visit, where the patient was asymptomatic, was having no discomfort, and now you've done all of these things to produce inflammation. And these people generally have more post-operative discomfort than if you treat a necrotic tooth. Now, if you're using a filling technique such as lateral condensation, where you can passively put the sealer in, passively insert the gutta percha, maybe less inflation. In fact, if I were going to do vital teeth, that's the technique that I would advocate for you. But the tooth that clinically will be perfectly comfortable after you do a one-visit root canal is a tooth with a sinus tract, a fistula, because you know this tooth is infected, you know the pulp is necrotic, but if you do really good cleaning and shaping and good irrigation, you've got it about as sterile as you're going to get it compared to these studies you've seen up there with intracanal medicaments. And if you fill this tooth in one visit, this patient cannot have postoperative discomfort because the fistula allows for escape of this pressure buildup and inflammatory response. And in fact, that is being caused by the bacteria in the root canal system. And when you eliminate that, you've actually improved the condition. So if you've done a good job, it will heal. The patient cannot have postoperative discomfort. For me, that's the perfect indication for a one-sitting root canal. Most clinicians don't like to do necrotic teeth in one visit because they're afraid that these teeth might flare up and cause swelling and postoperative discomfort. But the discomfort that someone is having because of a necrotic pulp is the results of the bacteria and their byproducts in the periapical tissue is causing the inflammation, pressure, discomfort, and doing your root canal procedure will improve that condition. Even your filling technique will not generally exacerbate this condition. It's already inflamed. If it's already inflamed, you can't do much more to intensify that. And in fact, your cleaning procedures and irrigation procedures generally lessen that effect. So necrotic teeth that are symptomatic, I've been doing endodontics one visit for probably 15 years, and when I was practicing full-time, I did approximately 2,000 root canals per year, and maybe 10 or 12 I had to go back and do an incision and drainage, but it's a very insignificant number. Whereas vital teeth that were a bridge abutment that I did in one visit, they hurt a lot and very, very frequently. Vital teeth, I put calcium hydroxide in the tooth, not to kill bacteria, because the first thing that calcium hydroxide does is it's tissue toxic. And you've already inflamed the periapical tissues and the tissue inside the lateral canals. Putting calcium hydroxide in the root canal system necroses this tissue. And I leave it in for about 2 weeks, bring the patient back, irrigate well, and then obturate. And by necrosing this tissue, generally the postoperative discomfort afterwards is considerably less than doing it in one visit with a vertical compaction of warm gutta percha technique. What about a tooth that's draining through the crown? Would I do that in one visit? Is that the question? If I'm having pus draining up through the root canal system, I continue with my instrumentation. I continue to make sure that the apex is not occluded with debris, and I enlarge the root canal. And generally speaking, within 30 to 45 minutes of cleaning time, this drainage, at least the pus portion of it, has stopped. You may have some serous exudate, kind of clear fluid, maybe a little straw colored. If I can dry the root canal after I've done my cleaning and shaping, I go ahead and fill the root canal. If I cannot dry the root canals after my cleaning and shaping procedure, I have two choices. One, to do a incision and drainage and fistulate into the lesion so that it can drain that way and I can dry the canal, fill the canal. Or if you don't do that, then just put your medication in there and bring the patient back to obturate at a second visit. I do not obturate wet root canals. So I've got to get it dry either by incision or bringing them back a second time. Whenever I lecture, oftentimes at a break, an attendee will come up and pull out some x-rays and say, Dr. Johnson, I did this tooth and I'm having this problem. What happened? What went wrong? Well, here's a case, and I hope you can see it, where during instrumentation the periapical areas look rather healthy. And at the fill appointment, they look rather healthy. But 6 months later, now you have a large radiolucency. And of course, this dentist asked me, why did this root canal fail? Now, I like this particular set of x-rays because you can answer the question depending upon your thought process. Well, it failed because bacteria is present. Why? Well, if you believe in coronal leakage, you can see that the coronal seal has been disrupted if it was ever present. So bacteria could come back down through here and reinfect the root canal. If you believe that excess filling material leads to a lower success rate, then you can say, well, it failed because you have an overfilling on this root. If you believe in cleaning and shaping all the way to the terminus of the root canal and filling all the way to the terminus of the root canal, you can say it failed because this mesial root was never instrumented and filled to the end of the canal. So whatever your belief system is, you can say that's why this tooth failed. How many in here are opposed to seeing excess filling material on the x-ray? In other words, how many don't like that look? Raise your hands. Only one, two, come on, admit it. Most of you were taught to stay within tooth structure. You'd prefer to see something like that. Now, so this is the part of this lecture that I'm going to deal, or I'm going to talk about apical extent of cleaning and shaping and obturation. This is a huge controversy in endodontics. And I like quotations. Here's one from John F. Kennedy. We enjoy the comfort of opinion without the discomfort of thought. In fact, your opinions, your philosophies that you embrace clinically were instilled in you by the textbooks that you read and the professors who taught you. That's it. That's your background. And any change from that takes a tremendous amount of evidence to get you to change. I was married and divorced 3 times, twice to the same woman. Now, somebody would take that as evidence that I'm crazy. Actually, I would tell you that I'm an optimist. I thought I was going to get it better, get it right. I have since remarried, and it's lasted for a year, so maybe it's working. Maybe I am getting better. But in the words of my second and third wife, Patty, she said, Ben, if it were not for guilt, you would have no emotional life at all. And I like that saying because I was taught to stay within tooth structure. and to fill within tooth structure. And when I saw excess filling material, I didn't like it. But as the years went by, I started believing, maybe I'm having more success cleaning to the terminus and filling to the terminus and having a little excess. But because I was taught to stay inside tooth structure, I always felt guilty when I saw this puff of sealer, because I was taught to feel guilty that way. Nothing is either good or bad, but thinking makes it so. Retreatment of endodontic fillings. This is an article by Gunnar Bergenholtz, and nothing significant about this article except they were doing retreatments of root canals for two reasons. One, it didn't look good, but the bone was healthy. Or two, there was still a lesion around the end of the root that was not healing. If the root canal just didn't look good, they had 94% success rate. If there was a lesion present that was only 48% successful, 30% were improving, and even if you combine those two together, you would see that you're way below your success rate if there is no bone loss. But when you read the article, it said further analysis of the material showed failures often accompanied by over-instrumentation and overfilling. Now, when you make a statement like that in a scientific article, you need to show the evidence. But there was no graph, there was no numbers, there were no tables in this article to substantiate that statement. And years later, I asked Bergenholtz, I said, why did you make that statement without showing the evidence? And he said, you mean we didn't show the evidence? I said, no. And you had lots of tables. He said, well, maybe we just all believe that. Well, this is a scientific article. Don't give me your beliefs, give me your results. The great enemy of truth is not the deliberate, contrived, and dishonest, but the myth, persistent, persuasive, and unrealistic. Remember that. I was giving this lecture on apical extent of root canal fillings last June to a group of endodontists. And I asked the question, what's the distance from the cemento-dentinal junction to the radiographic apex? And this one endodontist sitting on the second row said 0.659 millimeters. And I said, 0.659 millimeters? I said, I've never asked a question that somebody responded in 3 decimal points there. To the thousandth of an inch or millimeter. And I said, George, I said, that's not correct. That's the distance from the cemento-dentinal junction to the center of the foramen. He said, oh yes, I'm correct. You're wrong, Ben. So George, we'll argue about it later, but you are incorrect. And when I got back to Tulsa, I found 65 pages of a review document for endodontists that are taking the board examinations. And in this article, or in this review material, it makes the statement that Cutler in 1955 examined the apices of extracted teeth, and the distance from the dento-cementinal junction to the radiographic apex was 0.65 millimeters. This is in the study material for endodontists, and that's not what he said. In fact, I got the article from Sergio Cutler, Yuri's son, and looked at it. I have redrawn his original drawing to show you the distances. This, of course, is the cemento-dentinal junction on this side of the root canal, and this is the cemento-dentinal junction on the other side. This is the thickness of the dentin, and here are the distances from the cemento-dentinal junction to the center of the foramen. This is where the 0.659 millimeters is. And if you're going to measure the distance from here to here, you have to drop a perpendicular, and that turns out to be 0.931, as I recall. I can't remember now. Yeah, 0.931 millimeters from this point. And if you stopped your instrumentation here, it would be 1.1 millimeters to the radiographic apex. If you instrumented all the way to here, this would be the distance from the cemento-dentinal junction. If you stopped your instrumentation here and you obturated, the gutta percha would have to go in this direction, and that turns out to be 1.3 millimeters. So, and that goes on. There are other studies that the terminus of the canal is almost never at the radiographic apex, but quite a distance away. Now, so I get people talking about, well, I'm 1 millimeter away from the apex, radiographic apex, I'm within tooth structure. No, you're not. You barely are, if you are, but generally speaking, you're not. This article was published in the Journal of Endodontics in April 2005, well, 1 year ago. And the title is Determining the Optimal Obturation Length, a Meta-Analysis of Literature. Meta-analysis is a technique where they go through the literature, find all of the studies dealing with this subject, and then find the ones that have the same measurement criteria, similar recall time frames, similar techniques were employed, and then they combine these studies to arrive at a conclusion because these studies were all measured in similar ways. They started off with 60 studies. They narrowed it down to 4 studies. Now, in the beginning of this article, they made the comment that Seltzer and his colleagues advocated instrumentation and filling short of the apex. And they made the statement that Schilder advocated debridement and obturation to the radiographic apex. Now, when I read this, it got my attention because I have read all of Dr. Schilder's material. I've listened to him speak at least 25 or 30 times. I've never heard him say that. He always said to the terminus of the root canal, not to the radiographic apex. So I don't like to see someone misquoted in literature. Their hypothesis was that obturating materials confined to canal space would correlate to a higher success rate. And that's generally what you're taught in dental schools. And this is the graph that they use of all of these scientific studies that the 4 that they got. Group A had the highest success rate, except for Matsumoto, which Group B had the highest success rate. Now, there only were 4 teeth in this category, and so that's a very low number, so I don't put much emphasis on it. But Group A had the highest success rate. And their conclusion was that our hypothesis was proved. That is, confining obturating material to the canal space did indeed correlate with a higher success rate. Now, I haven't told you what Group A and Group B are yet. And when you go back and look at it, Group A is 0 to 1 millimeter, which I've already shown you is not in the canal space. It's in periapical tissues. And Group B was 1 millimeter short of the radiographic apex, but not as far as 3 millimeters. Group C was past the radiographic apex. They have their facts right, but they've drawn the wrong conclusions. It is not fine in canal space, it is overfilled. And it had the highest success rate in 3 out of the 4 studies. So their hypothesis that staying inside tooth structure led to the highest success rate on the articles that they chose to present was wrong, because 0 to 1 millimeters is in the periapical tissue. Therefore, the hypothesis is null and void. Now, Matsumoto, his article was entitled Factors Affecting Successful Prognosis of Root Canals, and I can't very well argue with greater than 1 millimeter short, which is in tooth structure. He had the highest success rate, but it's only 4 teeth, so it stands as it stands. The other article, Hardy et al., was a very good article. They recorded the age of the patient, periapical disturbances, whether they went into the periapical tissues to establish drainage, or it was overextended working length x-ray, or over instrumentation, or sealer through the apex, or excess filling material. Whatever reason, they recorded it. And they had large numbers, had a 90% success rate, 10% failure rate, over 1,100 teeth. On the age, I like this very much because you can see in the over 60 category, this has the highest success rate. And now that I'm 62 years of age, I like that. And if you want to be very successful in endodontics in your practice, don't ask the patient their age, because if you don't record it, you have a 100% success rate. So, don't keep good records and your success rate goes up. I'm only joking there. But the root length of the filling materials, if it was 0 to 1 millimeters, here is 500 teeth. 525 out of 567 was successful there. This is very large numbers, statistically significant. So they had the high success rate, and it's in periapical tissues. Now, don't get me wrong. I am not saying filling material in the periapical tissue is a good thing. What I'm saying is getting all of the debris out of the root canal system and filling all of the root canal system is a good thing, even if you have the consequence of a little filling material in the periapical tissues. You understand what I'm saying? I'm not saying it's good to have it in the periapical tissues. I'm saying that that is a negative that you endure for the positive effect of getting all the debris out of the root canal and filling all of the root canal. I would prefer to see a little excess than none, because now I know everything is out of the root canal. So, high success. And on the cases where there was a periapical disturbance compared to no periapical disturbance, very high success rate. That was their highest success rate overall. So doing something in the periapical tissues contrary to what you have been taught is not bad. It's good. And here's a long-term technique. This is a very good study. 91% successful, so that's pretty good. And they have this table that they correlated. Now, this is an excellent table for you to look at and judge your work. And you've got to look in the mirror and be truthful with yourself. Do I instrument the root canal system well? Do I obturate it well? And answer yourself truthfully, and this will give you a guide as to which teeth you should treat and which teeth you should maybe call your local endodontist about. Two categories, vital and necrotic. Let's look at the vital case. If it is adequately instrumented and adequately obturated, and you're more than a millimeter short of the apex, success rate is very good. If it is vital and you adequately instrument and adequately obturate the root canal, and you're overextended, because plus or minus 1 millimeter is overextended, your success rate is still very good. If you're overextended more than a millimeter, your success rate is still good. So this is telling you, if you're working on vital teeth and you are technically adequate in doing root canals, do all the vital teeth, because your success rate is very high. But when you look in the mirror and you say, well, I'm not very good technically, then watch it. Because if you're short more than a millimeter, it's a coin toss. It's a 50-50 chance of whether the root canal will work or not. If you're a little bit overextended, you still are only 2/3 successful. And of course, if you're overextended, there were none in that category, so you don't know, but I would still guess that the success is not very good. Necrotic. If it is necrotic with a bone lesion, and you are you're adequate in your techniques of doing endodontics, and you're short more than a millimeter, you're hitting about 86% success rate. If you are at the apex plus or minus 1, which is telling you you're in periapical tissues, your success rate is much higher. You're shooting in the mid-90s as far as success rate goes. If it is necrotic and you're adequate and you are extended over a millimeter, you are still in the 90s for success rate. This is telling you, remove all of the debris, remove all of the bacteria, and fill to the terminus. And if you do this adequately, your success rate is very, very good. On the other hand, if it's necrotic and your techniques are not so good, then if you're short more than a millimeter, you fail. If you're in periapical tissues a little bit, you have a 50-50 chance. If you have overextended and transported the canals, you're still very bad. What does this graph tell you? It tells me what my professor told me when I was a student. Success in endodontics is almost solely dependent upon the skill of the individual operator, not the technique, not the material. Almost solely dependent upon the skill of the operator. So if you are skillful, and you've heard what I've had to say about cleaning and shaping to the terminus, you'll see that that is substantiated as the highest success rates, contrary to what some clinicians and some speakers say. Here's another one, the Carrick study that was in there, and the purpose of this study was to judge general practitioners versus students in the mastery of the OSPI technique. And OSPI advocated cleaning to the terminus and using chloroperca technique. And they used, the general practitioners did approximately twice as many teeth as the students, and they did a 3 to 5 year recall on these cases. Now, something was disturbing that they found. Only 20% of the cases done by general practitioners were technically adequate. But more disturbing was only 50% of the cases done by the students was technically adequate. So they were very perturbed by that. But in cases that met ideal technical standards, success rate was 92% and 93% respectively. So if you do it right, it will work. But they were upset that the students weren't doing a much better job. And when you compare add these groups together, you can find out that overfilling by more than a millimeter was not very efficacious. And of course, in the meta-analysis, they forgot to add those together, so they were way off base in that. That's not important. Now, in the discussion part of this article, Osby stated excess filling material does not prevent periapical healing, but is often associated with a defective apical seal. Statement very similar to what Schilder had made. This view is supported by the results of this current investigation. So he's even saying that excess filling material, or this article is saying excess filling material had no effect. But the people who did the meta-analysis used this article to say that it did. Here's another, I don't know how it sounds in Spanish, but statistics are like lampposts. They're often used for support rather than shedding light on the subject. And since I am talking extensively about this, I want to show you some other articles that substantiate overfilling is not bad. I know both of these authors. They took all of the teeth that they had overfilled on, brought them back for checkup x-rays 5 or 6 years later, and these were all the teeth that had overfillings over an 11-year time frame. If there was a radiographic lesion, they had a 96% success rate on all of these overfills. Without a radiographic lesion, they had a 100% success rate. Not a single failure with an overfilling if it was a vital tooth. And extruded material had no effect on success. Resorption was the same. Resorption of this overfilling material was the same if it had a lesion or no lesion. And sealers did not cause irreversible lesion development in vital cases. Now, this is a study that I saw presented at the American Association of Endodontists meeting in Seattle, say about 8 years ago. And this was a Brazilian dentist who did this. He took dogs, vital teeth, over-instrumented about 3 or 4 millimeters into the periapical tissue, and he did it with 2 classifications of files, a size 25 or a size 40. And it really doesn't matter because the results were the same. And some of these, he sacrificed these dogs immediately post-operative, and as you would expect, you would see a dense inflammatory reaction, no tissue invagination, no calcification, because it's only been a couple of days afterwards. And whether this was a size 25 or a size 40, this was the same reaction. A half a year later, 6 months later, tissue growing up into the root canal with some calcification occurring. No inflammation at all. 1 year later, more calcification occurring, no inflammation on any specimens. And when I saw this, I was sitting next to a friend of mine, Jim Gutman, and I said, Jim, I said, that's pretty interesting. He said, Ben, don't get excited because dogs' teeth have a lot of accessory canals, and this collateral circulation helps overcome the damage done by this over-instrumentation. Made sense to me, but somewhere in the back of my mind I was thinking, oh, I know something different. And sure enough, it took me a little while, but I found the article by Osby on human patients. He overextended upper cuspids 3 millimeters into the bone, instrumented, and afterwards intentionally underfilled the root canal system. And he used Hedstrom files, which transport canals dramatically. And you can see the straight line of this dentin where he transported the canal. And 7 months later, when he went in and took this block section, you can see perfect periapical tissues. You can see cementum growing down inside the dentin, healthy tissue growing inside it. This is demonstrating what I have just told you. If it's a vital case and you've over-instrumented, don't worry. It isn't going to bother you. And of course this is underfilled, but had it been overfilled, you wouldn't need to worry anyway. And this shows you how hard this tissue is that grows in. It completely sealed off the apex. And this is an interesting study because it's quoted a lot. The overall success rate was 91%, vital pulps 96%, necrotic pulps 86%, retreated teeth 62%. Root filling excess had no impact on success of vital cases. Not a single one was it detrimental to. But for those people who would advocate staying inside root canals, this is the case they often quote, because when a lesion is present, instrumented to the apical constriction gave you 90% success rate. Instrumentation short of the apical constriction dramatically drops the success rate. So this is telling you, clean to the terminus of the root canal. But people who quote this article will say, do not fill past the apex, because 0 to 2 millimeters from the apex inside the tooth gave the highest success rate, 94%. Greater than 2 millimeters inside the root canal gave 68% success rate if there's a lesion present, which is telling you, if you're going to be short, don't be short more than 2 millimeters or your success rate is really decreasing. If you had excess filling material past the radiographic apex, 76% success rate. 94%, 76%. Therefore, they will say, do not overfill, because if you fill past the terminus of the canal, you will have a lower success rate. That's not what this article says. It says if you fill past the radiographic apex, which means you've probably over-instrumented a bunch, because this 94% from 0 to 2 millimeters, we already know. Half of this success rate is because it is in periapical tissues, which is 0 to 1.3 millimeters. So when people quote this article to substantiate saying in tooth structure, you got to know this difference in order to argue with them, because they have no leg to stand on. This is another one. This is a very complicated study. There was a prospective study, which is very good. They used many different sterilization techniques, but all in all, fill to the apex and excess, again, success rate was above 90%. Apical level of root filling did not influence the outcome of endodontic treatment. Over-instrumentation and overfilling retreated root canals. Study effect. They even made the comment that filling flush with the apex was not classified as overfilled, which is unusual, but again, made the statement overfilling was not the cause of failures. This is the article that as an endodontist you can prove pretty much anything you want. Sjogren, Figdor, and Sundquist are all rather conservative clinicians. They prefer to do things in 2 visits. And this was a prospective study. They took 55 necrotic teeth with lesions. They opened up into them. They cultured them. Not surprisingly, all 55 teeth had bacteria in them. They instrumented and irrigated, prepared to obturate the root canals, and they cultured them again to find out if they were sterile or not, and then they filled these roots. And they followed the cases for 5 years. And of course, the unstated aim was to show that if you had put intercanal medicaments in, you might have more teeth that were sterile. Your success rate might have come up versus do it in one visit. Now, what they really found was, after instrumentation and irrigation, 33 of the 55 teeth, which is about 60-65%, showed a negative culture, and they had a 94% success rate. If bacteria were not present, 94% success rate. On the ones that failed, they did apicoectomies, recovered the root ends, and found bacteria in accessory canals. Of the 22, 1/3, that still had bacteria in them, they had a 68% success rate. You would expect that, or at least they expected it. Interestingly enough, in the middle of the article, they mentioned that 10 of the teeth had slight overfillings. And as you know, slight overfillings have been associated with reduced failure rate. And I hope that I've given you enough evidence that that's no longer what you're thinking. 5 of them still had bacteria, 5 of them were sterile. And very interestingly, all 10 were successful. And this study, their conclusion was, shows the success rate of endodontic treatment is 26% higher if the root canal is free from bacteria than if it is infected at the time of obturation. And we know other studies that show that sterile canals, higher success rate than infected canals. Now, you could also draw the conclusion from the evidence presented that root canal treatment is 100% successful if slightly over-instrumented and overfilled, regardless of the presence of bacteria, because their data shows that. Now, I'm just saying this as a joke, but I'm saying it to emphasize that instrumenting to the terminus and filling to the terminus, even though it results in a slight overfilling, maybe, not only maybe, is a good thing in necrotic cases. And this study proves it. Because what we know and what we often forget is that the terminus of the canal averages 1 to 2 millimeters from the radiographic apex. We know it from Cutler's studies back in 1955. We know it from Dr. Bresenio's studies that have just recently been published. We know it, we forget about it. And what Schilder actually said was optimal cleaning and shaping are achieved by preparing the canal to its radiographic terminus, not apex. This is also what Osby said. This is what Ben Johnson is also saying. And it is not true because we said it. We are saying it because it is true. This need not be, and rarely is, the geometric apex of the tooth. Even sophisticated clinicians never translated to the apex as the geometric apex of the root. To work to the radiographic terminus of the canal is to work minutely through the foramen. That's what Schilder taught. Going back to this chart on cognitive dissonance, this is the triad of endodontic success: thorough debridement, sterilization, and complete obturation. And it is my belief that cleaning to the terminus of the root canal is very important. and obturating to the terminus of the root canal is very important in order to clean as good as you can, and of course to sterilize also, and again with obturation. Now, if you were taught to determine the working length, in other words, find the cemento-dentinal junction, and then subtract a half a millimeter or a millimeter, instrument to that point and clean to that point, what's in that last half millimeter or millimeter? That's debris. Now, a lot of professors and a lot of schools teach you this technique for doing root canals. Now, why do they do this? One, they believe it because they were taught that way. Secondly, this is a way of grading your excellence. Because if they tell you to stay within tooth structure and you see this big piece of gutta percha coming out the apex, you didn't do what they said to do. So there has to be a grading system in any educational institution. Now, I don't think that they consciously do it that way, but it is a technique of judging your excellence. Now, ask your patient. A patient comes in, it's a lower molar or bicuspid, whatever. It has large cavity. You can see the canal on the x-ray. You can see the periapical radiolucency. And you hold the x-ray up and say, now, Mrs. Smith, you need to have a root canal. And when we do a root canal, we remove this decay, enter the pulp canal, and you can see this little dark line in the center of the root. And we clean this tissue out of the root canal, and we sterilize the canal, and then we fill the canal, and then this dark area that you see in the bone, where the bone has been destroyed, that should heal back up, and then we can put a crown on the tooth, and you'll be fine. This is your explanation to the patient. And then you say, now, Mrs. Smith, there is controversy within my profession. Oh, by the way, this treatment is going to cost you $200. There is controversy in my profession. One group believes in completely cleaning all the tissue out of this root canal and completely filling this root canal system. The other group believes in cleaning all the tissue out except for that last millimeter and filling the root canal except for that last millimeter. Which technique would you prefer that I use on you? Well, Dr. Johnson, I'm paying you $200. I want you to take it all out and I want you to fill the entire canal. This is not rocket science. Your patients will tell you what to do. I don't care what the textbooks say. I don't care what the professors say. This does not make sense. And when they do surgery on a cancer patient, they don't take an operating microscope and say, this is a cancer cell and this is a healthy cell. You don't take your little scalpel and go like that. What do you do if you have cancer? You make a big incision. You don't want to leave anything, so you take a lot of healthy tissue out. And I was just having an interesting discussion while you were enjoying your break that I've had many cases in my life that have not gone well. And when everything isn't working, I over-instrument the canal and I overfill the canal. Because I had the most times I ever saw a patient was 10 times. And about the third visit, he said, Dr. Johnson, is this going to work? And I looked at him and I said, well, I don't know. But as long as you keep coming, I'm going to keep trying. And on that 10th time, I looked him in the eye and I said, look, I'm getting tired of seeing you. And I know you're getting tired of coming. And I've already lost money on this tooth. So today, we're going to over-instrument into this periapical lesion, and we're going to overfill. I'm going to do the best I can at removing tissue and sterilizing and filling. And if it doesn't work, then we're going to do surgery. And so I did exactly that, and it worked. And it stopped this coming back and coming back. So when all else fails, I over-instrument and I intentionally overfill. Don't do that on everybody, but do go for the terminus of the canal. Now, we're going to talk about some new advancements in endodontics. And recently, when I say recently, the last year or two, there's a new obturating material that has been introduced in the U.S. Is it available here in Guatemala? Resolon. It's a gutta-percha substitute, polycaprolactone or something like that. It is a polymer, is this cone shape. It feels like gutta-percha, it looks like gutta-percha, it is not gutta-percha. And the sealer that goes along with it, they call it Epiphany. Actually, there's several different brand names, but it is a similar substance to the Resolon, and it bonds to the Resolon, whereas sealer does not bond to the gutta-percha point. Now, they claim that it moves into dental tubules and that it creates a monoblock. Monoblock is an advertising term. This is not a scientific term, but you'll hear endodontists talking about a monoblock obturation because advertising catches our attention too, and we start using advertising terms. Is it better than gutta-percha? I don't know. The first couple of studies that came out were very positive. The next two or three, not so positive. I'm not going to belabor this point like I did where do you want to be, short, flush, or long, this morning, but I am going to go through it briefly and a little bit of thermophil. Then we're going to get into instrumentation and new advances in instrumentation. But Resolon is on the market now, and it's been last couple of years widely researched. And you'll see a photograph, something like this, an SEM photograph, in some of your journals talking about the Resolon point in the Epiphany sealer. And look at everything, and you'll see here's the dentin, and here's the sealer coming right up to the dentin, no gaps in it, and you don't see where the sealer meets the master cone there because it becomes one single obturation, hence the term monoblock. And if the dentinal tubules are open, if the smear layer has been removed and you decalcify the dentin, you can see where the sealer moves into the dentinal tubules. And you can think in your mind, okay, this sealer is moving into the dentinal tubules. When it hardens, this will tend to hold things together. And one study showed that, other studies not so good because you have the hybrid layer and things like this. At any rate, I'm not so worried about this because they think it's a great advancement, but I don't know. If you took an SEM up here, you can see a gap. So they didn't show you this area, and you'll find this in any obturation technique. Comparing it to gutta-percha, they'll show you a gap up here. But these are scanning electron micrographs, and when you process these things, you have to dry them and coat them with gold and stuff. Look at the crack in the dentin here. I don't think these cracks or these gaps occurred naturally in the root canal. I think this was a processing defect that occurred. And they'll show you something like this. You'll see the crack between the AH26 and the dentin. Now, when I first saw this, I went, whoa, wait a minute. That doesn't happen with the AH26. Because we know from other studies that this is where they put India ink or carbon black, I've forgotten which it was, in AH26, obturated the root canal, and you can see the gutta-percha obturation wasn't that tremendous, but the resin sealer actually moved to great depths within the dentin, and you can tell that from the dye that they put in the resin. So resin sealers can penetrate dental tubules also. And here you see it where the dentin has been decalcified, and you can see the resin sealers moving in there dramatically. In fact, if you take a high power view, you can actually see communications between dental tubules, and the resin sealer was able to get into there. So we've known this for at least 2 decades, that resin sealers will penetrate dental tubules. Now, if for no other reason the sealer bonds to the master cone in Resolon, that is an advancement over gutta-percha sealer. Is it worth the extra money that you spend for it? I don't know. That's a choice. But there have been probably now 15 to maybe 30 studies that have investigated Resolon, comparing it to gutta-percha and sealers. I find it amusing that probably half to 2/3 of the ones comparing Resolon with lateral condensation shows Resolon as good as, if not better than. But I only know of one study comparing it to vertical compaction of warm gutta-percha, and the vertical compaction of warm gutta-percha was better than Resolon as far as dye penetration goes. I haven't seen any of them comparing it to Thermofill. Thermofill, I think, is an excellent obturation technique, and I will tell you that I am biased because I invented it. So you know that. But I invented it for one reason. For these long curved canals or small canals. When you have a curved canal like this, your your spreaders and your gutta-percha pluggers never go past this point. And we know from literature, if you're not condensing the gutta-percha, it has no advantage over silver points. And we don't like silver points. So you need to condense the gutta-percha. And with carrier-based obturation techniques like Thermofill, you can condense all the way to the terminus because that carrier condenses the warm gutta-percha. And you can get nice, predictable obturations like this around severe curvatures with this technique. Now, this is a cleared tooth that has been rehardened. In the upper canal, we're going to obturate it with Thermofill. In the lower canal, we're going to obturate it with System B. There's no sealer in here, so you can see the flow of gutta-percha. This whole obturation took less than 1 second to fill that canal, but it has been slowed down so you can see the flow of this gutta-percha into all of these isthmuses and little canals as the carrier is taking the warm gutta-percha into the root canal system. And you can see how it fills this accessory canal. You can see how it fills these isthmuses. You can see the carrier resting against the dentin right here. And you can see the gutta-percha reaching the apex. Very well obturated. Now we're going to obturate the lower canal with System B. You can see some of the fluid in here coming out the apex. We thought we had it dry, but we couldn't dry those areas, so that got forced into the lower canal. And you'll see a little void here. You can see the carrier resting there on the Thermofill. Turn it over and look at the other side, and you can see nice obturations. Is one better than another? Who knows? But it did completely obturate the root canal system. Now, we do know from work that has been done not only in Italy but in Turkey, 4 different articles in the endodontic literature shows that with Thermofill, the Thermofill actually will penetrate the dental tubules if the smear layer has been removed. And in this case, after the obturation, they just crack the dentin to pull it apart to examine it, and you can see the gutta-percha in the dental tubules. You don't see that with lateral condensation or vertical compaction of warm gutta percha. And here's a higher view with sealer, and you can see the sealer and the gutta percha entering the dental tubules. You don't get better adaptation than this. That's as good as it gets. And here's another one with a fractured segment showing the gutta percha in the dental tubules. Here's one where they obturated the root canal. They decalcified the tooth, and with a scalpel, cut it, buccal and lingual, and pulled the decalcified dentin away from the obturation. Here's the obturation, a scanning electron micrograph of it. And here is the decalcified dentin, and you can see the gutta percha perfectly matches each one of those dental tubules. So you can see how the gutta percha actually fits into it. So very close adaptation. And in the literature, very little leakage is recorded with literature. With the use of thermofill. Do all obturation methods work? Most filling techniques can experience success, except that the best of lateral condensation cannot forgive a too small access opening and deficient convenience form. Vertical compaction at its best will not forbear the missed canal or flawed diagnosis, nor will the quintessential paste filling overcome inefficacious canal irrigation. And intolerable to all obturation methods is inadequate canal system debridement, cleansing, and shaping during preparatory efforts. This is Daniel Lassiter, who was my clinical partner for about 8 years. Beautiful statement. Obturations will work, but only will work if you do the shaping and cleaning and convenience form. Now, I showed you this x-ray earlier today, and of course the guy asked me why it failed. Well, it didn't fail because it was overfilled. I hope you believe me now. It may have been coronal leakage. It may have been because debris and bacteria were left in that area. Or it could be that there's debris in this canal that you can't see. Equally puzzling is, why did this case work? This is 28-year recall. 28 years. And there's no periapical radiolucency. There's no problem in the bifurcation. They never did a root canal on this root, and only half of a root canal in this root. And here's a perforation going into the periodontal ligament. Yet this case worked. Why? Because the bacteria that are present are in such a small number that the body can overcome that effect. Mother Nature is very forgiving. I wish she were forgiving on the cases that look good, because I hate to do a good-looking case and have it fail. It's very detrimental to my ego. Now, what's the most important step in successful endodontics? Obturation? No. Sterilization? Getting rid of the bacteria? Yes, but you cannot sterilize a root canal unless you remove the debris from inside the root canal. What's the first thing that the physicians do to a trauma patient when he's brought into the emergency room? They debride the wound. They clean the dirt, the gravel. They clean away the dead tissue. And then they start doing their procedures. Because if you don't get rid of that, the other attempts that you do at sterilizing this or disinfecting this wound will not work. You first have to do the debridement. And we'll talk about that today. Now, some of you who use rotary nickel titanium, and this is a very simple root, relatively circular canal, You just take an instrument, go down in it, enlarge it, and you think everything is fine. Well, canals are not circular. They're elliptical in shape in a buccal-lingual direction, and we'll come back to that. In this case, you see the isthmus. You come down this canal, and then you come down this canal, and you think you're through. You're not, because there's tissue in here. You need to use small instruments and go down the buccal aspect, tilt the contrangle and come up the lingual, and keep repeating that process. Or here's a distal root of a lower molar. You come right down the center, enlarge it to a size 50 and think you're done. No, because you have tissue here and here. You've got to go into those areas with small instruments and remove the tissue. Here's that simple canal again. Take a hand instrument, pre-curve it, scrape on the buccal and lingual walls, and look how much debris is there. Because rotary instruments pull out tissue fine. They instrument easily, but these buccal and lingual ramifications, they actually push tissue there. So you've got to go back, bring it into suspension, then irrigate it out. And the instruction booklets don't tell you that. You've got to know that by knowing endodontic anatomy. This is a mesial buccal root of a lower molar. An Italian endodontist friend of mine, Augusto Malantacca, has developed a technique where he thins these roots with a diamond disc. He clears them so that you can see it. He recalcifies them. He mounts it on a slide and covers it with super glue so that you can prepare these canals. You can watch what you're doing. Have Augusto Malantacca instrumenting, Giuseppe Cantatori, and myself. You have 3 talented endodontists able to see what they're working on, doing the best job of cleaning and shaping we can do. You can see an accessory canal here. You can see an isthmus coming between these 2 root canals. You can see an apical opening here, an apical opening here, all sorts of ramifications. This is not unusual. This is the normal. And Hess showed us this back in the early part of the 1900s. And here it is obturated. Look at the tissue remaining. Look at the tissue remaining. And we didn't even get into these canals, therefore we didn't obturate it. But when you take a radiograph, this isn't a void, it's tissue. But if you turn this radiograph and looked at it the way you see them on your patients, you'd think, oh, this is well done. It's not well done. Now, the first thing that I think of in the morning when I wake up is I'm as handsome as Tom Cruise. And then I walk into the bathroom and I look in the mirror and I go, oh, Tom, you had a bad night. Your hair has turned gray. You have wrinkles all over your face. You know, your chest is dropping a little bit. And I naturally suck it in as I go to the toilet. Now, I'm 62 years old. I've been married and divorced 3 times, twice to the same woman. I have remarried again, so I'm an optimist. I have raised 3 children into their 30s. I have an adopted daughter who's 17, so I'm going through that process again. I'm an endodontist. An endodontist is a stressful occupation. I'm an entrepreneur. I started a company. It happened to be successful. Lots of stress. I'm a pilot. I'm a scuba diver. I ride Harley-Davidson motorcycles. Lots of stress in my life. Now, Tom Cruise is starting to accumulate a lot of stress in the last 2 or 3 years, what with his love affairs and whatnot. And in reality, when Tom Cruise gets to be 62 years of age, he may not look as good as I am. But I sure as heck don't look as good as he is right now. But that's my thought process. I don't want you to center on how difficult endodontics is. I want you to center on what a good job you can do. But don't forget how complicated it is. That's the whole point of me going through this discussion with you. Think positively, but don't forget reality. Now, Here's a friend of mine, John West, up in Washington State. John wasn't real happy with Thermofill when it came out because he believes in vertical compaction of warm gutta percha. And we both spoke at the same meeting, and it was very interesting because his lecture followed the same format as my lecture. And afterwards he came up to me and said, "Well, Ben, you presented very good cases. Did you just present your good ones?" And I said, "John, did you just present your good ones? I mean, when you're standing in front of an audience, do you think I'm going to show you my bad cases? No, I'm going to show you my good cases." So for a week, we exchanged all of the cases we did, good and bad. He sent me every one he did, I sent him every one he did, and we arrived at a mutual admiration point. He's a good endodontist, he thought I was a good endodontist. And he realized that Thermofill is a form of vertical compaction of warm gutta percha. Now, I want you to look at this case. Here it is preoperatively. No problems here, you don't think. Little calcified in the upper portion of this root, but any endodontist could do this case, and most dentists could. I'm going to show you his fill x-ray, and I want you to grade him on this case. Nobody's keeping score, so I want everybody to raise your hand, okay? The choices are A for excellence, B for good, C for fair, D for, he could have done a lot better, okay? Here's the fill x-ray. How many think he deserves an A? Raise your hand. Excellence. Okay, how many give him a B? Good. How many give him a C? Fair. I don't like to see all that excess sealer, even though I believe in it. How many would give him a D? Okay. Now I'm going to give you an angle shot. Same tooth, taken from an angle. Look at this little loop that he obturated. Look at this loop that he obturated. How many give him an A now? Raise your hands. Okay. How many give him a B? Raise your hands. How many give him a C? How many give him a D? Okay. A lot of you B's moved up to A's then. I'm going to give you an extreme angle. Now you see all of these ramifications that he obturated. How many give him an A? Raise your hands. How many give him a B? Raise your hands. Okay, how many give him a C? How many give him a D? You see, we're different because repeatedly you raised your scores. I give him a D. You know why? Because he missed a canal. He missed a canal. Now, radiographically, and you're judging radiographs. Radiographically, you think, gosh, look at all these ramifications he obturated. It's not what happened. This is tissue. 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 This is all tissue he didn't take out of the root canal system. You got to think at it differently. The x-ray looks pretty because you think he did a great job of filling it. No, he did a horrible job of cleaning and shaping it. And this is not that tooth, but it's one very similar. Excellent job of obturation. And here's the isthmus running over to the other canal. But look at this tissue. Look at this tissue. Look at this tissue. And all of this is within a millimeter and a half of the end of the root. And we know that most root canal fillings, if they're not Thermofill, will leak 2, 3, 4 millimeters. And this allows, because this tissue is just full of bacteria, this will allow communication of bacteria to the periapical tissues. The problem is removing this tissue. This is the problem that we face. Right facts, wrong conclusions. Yes, the obturation looked great, but there was still tissue. Now, I haven't even explained what a passive instrument is and what an active instrument is, so you can't adequately answer this question. Nickel titanium instruments come in two categories, active and passive. The passive instruments, well, all instruments are machined from a round piece of metal that has been tapered to the appropriate taper that you're using, whether that's an O2 taper, an O4 taper, or an O6 taper. Now let me tell you what tapers mean. If it's a size 20 at the tip and it's an O2 taper, 1 millimeter back, it's a size 22. One more, it's a 24. If it's an O4 taper and it's a 20 at the tip, 1 millimeter back, it's a 24. And one more, it's a 28. If it's an O6 taper and it's 20 at the tip, 1 millimeter back, it's a 26, then a 32. You've got the picture. Okay, that's your tapers. Now you have this circular tapered rod and you machine the shape of the instrument that you want. If it's a passive cutting instrument, there are grooves that are cut alongside, 2, 3 grooves usually, and it leaves part of the original circumference of this tapered circular rod. This is called a radial land. And this radial land will scrape dentin. This is a passive cutting action. The active cutting blades will have a triangular shape of some sort, and we're going to go into it in detail, but it'll have a triangular shape or a square shape cut into it, so you have sharp edges. You don't have a radial land. And those sharp edges, as they turn, will actively cut dentin. These instruments work entirely different from one another. Now, there isn't really anybody in here as old as I am, but we were taught circumferential filing and reaming actions. And we believed a lot in this circumferential filing. You'd go to the apex, you would move this instrument 15, 20 times, it'd feel a little loose, then you'd go to the next instrument. What we were doing was transporting the canal a little bit, probably pushing debris apically. Sometimes we created a ledge, sometimes a perforation. Now the reaming action, particularly as you moved apically, continued to cut on dentin and continued to keep the instrument centered. Jim Rohn developed this technique of balance forces back in the early 80s. And since then, we've kind of gone that direction versus circumferential filing. Circumferential filing is not good, but some guys as old as I am like to do this motion. This motion with endodontic instruments that are nickel titanium mechanized does you no good. Don't do it. Okay? Just a flat statement. Now, active cutting blades transport the root canal system more than passive instruments. Is this good or bad? Well, it's not a good thing unless you intentionally want to relocate the orifice or intentionally want to straighten the canal, but I will tell you that that's not a good thing. And if you use this up and down brushing action, active cutting blades will transport a canal dramatically. Now I'm going to show you the use of passive blades. In the marketplace, profiles Profile GT instruments, Cybron's K3 instruments, and Lightspeed instruments all have passive blades. The other instruments have active blades. That would be ProTaper, Sequence, Guidance, and in Europe there are other brand names. Can you think of any other brand names that are here in Guatemala that have active cutting blades? In other words, well, Hero is the same thing as Guidance. If you have Hero instruments here, that's the same thing as Guidance in the U.S. Now I'm going to show you passive cutting blades. Like I said, this would be Profile, Rotary GTs, Profile GTs, or K3. Any of those will produce this same result. K3s are a little stiffer, a little greater torque strength than the others, but you primarily use an orifice shaper, a big instrument to open up the coronal portion, a little bit smaller when going deeper in the canal. When you meet resistance, go to a smaller size. Taking a 2506 around the first curve, about to enter the second curve. Drop down to a 2504 taper instrument. Go to the apex. Now, don't go back to the apex, but if you do, you'll see the instrument stays well centered. It does not change curvature. It does not transport the root canal, because these radial lands, as they're hitting the dentin that's already circular, it cannot cut anymore. It will stay centered. You can enlarge it to a 2506 if you want, and you can go back to the apex if you want. It will not transport the root canal very much. You can see a little debris accumulating here, so there's a little bit, small amount of transportation occurring. These instruments generally require the use of 4 or 5 instruments when you're instrumenting a canal. Active cutting blades, the manufacturer will say they're quicker, they're more efficient. They use positive terms. Let me ask you a question. I want you to tell me which term has the positive connotation. Beautiful, ugly. Beautiful has the positive connotation. Tall, short. Tall has the positive connotation. Slender, fat. Which has the positive connotation? Slender. You're thinking this way. Efficient, inefficient. Efficient. Quick, slow. Quick. So if somebody is talking about, dangerous and safe, safe has the positive connotation. If somebody is marketing you an active cutting blade and they say they're quick, efficient, they don't say dangerous. They don't say dangerous. So you use positive terms to describe what you're trying to sell. I want to put some realism in your choices that you make for your instruments. This is the use of a passive blade. I don't care if it's Profile, I don't care if it's Profile GT, I don't care if it's K3. And we're going to get into more differences in those in that category. Now I want you to see an active cutting blade. This could be Sequence, it could be Guidance, it could be ProTaper, it is ProTaper, it could be Hero, it could be any active blade. And they'll have you use something to open the orifice. In the ProTaper system, that would be the Shaper 1 or the SX instrument. Shaper 1 is a size 17 or 1802 taper at the tip, and it has big tapers in the top part of the blade. Really opens the canal dramatically. Followed by a Shaper 2 that is a 2004 taper. Now, if you go back, and this curve is not as severe as this curve is, if you go back with a Shaper 2 repeatedly, you'll see it start to transport the canal here, transport the canal there, and with repeated turns, these active cutting blades, if they are not cutting dentin, moving apically, they are transporting the canal. In other words, they have to be supported by dentin. Each insertion has to be deeper than the previous one, and when you reach the apex, you get out and you do not go back. Here's a finisher 2, which is a 2508. You noticed each insertion was deeper, and the cleaning, the shaping was beautiful. But if you go back just one more time, and this is the same block, going back with a finisher 2, one more time, you'll transport. You have completely eliminated your curvatures. You now have only one gentle curve. You've transported the canal dramatically. Dangerous. Now, can you use an active cutting blade properly? Yes, I showed you how. But with active cutting blades, each insertion has to be deeper than the previous one, and when you reach the apex, get out. Don't go back again. You now have to use a larger one, either a larger taper or a larger diameter, so that it is actively cutting on dentin as you're moving apically. Some clinicians talk about a brushing action to relocate the orifice, to straighten the canal a little bit so it makes your treatment easier. That's okay, as long as when you put the instrument in, you don't go around that first curve, that mid-root curve, and you use your brushing action there. Because if you're going around the curve, you are transporting into the bifurcation or trifurcation. Any questions about what I've just said? Now let me show you some examples. This is a research study that was published in the International Endodontic Journal. This is a micro CT where you put a tooth in a micro CT scanner and you scan the tooth, and then you instrument it and you rescan it again. And we've got 3 different colors here, so I want to explain them to you. The green was the original canal, and you can see this distal buccal root had nice beautiful curves to it, very similar to the plastic block. And post-instrumentation, the red is where the instrument never touched the canal walls. And when you're instrumenting in teeth, approximately 40 to 60% of the canal surface is never touched by an instrument because they are elliptical in shape. And the instrument finds the path that's easiest to negotiate. With this brushing action that the clinician used, you're highlighted in blue here, pale blue. This is the finished preparation. You can see that the canals were transported dramatically, almost made straight. You can see on this palatal root how it transported the canal to the outside of the curve, and here it transported it to the inside of the curve. So with these brushing actions, you will have transportation. Now let's look at another case. This is another micro CT scan done by a different researcher. It's on the mesial root of a lower molar. This curvature is not severe. This is just moderate curvature. And in this canal, he used a passive instrument. He used a K3. And in this canal, he used an active instrument. He used a pro taper. Any passive instrument, any active instrument would have given the same results, because this clinician used a brushing action all the way up and down this canal trying to relocate the orifice. And when he did that, after instrumentation, you can see that the passive instrument kept it pretty circular. Of course, you have to know it would have pushed debris here. The active cutting blade moved the canal into the bifurcation, which would have pushed debris in this direction, and this direction, and this direction. So keep that in mind. I keep telling you about pushing debris because cleaning this debris out of the root canal system is so very important. And here is your pre and post instrumentation superimposed over one another. Here you can see how it's very important where I said take a small instrument and let the tip ride down the buccal wall, and tilt your contrail, let it ride up the lingual wall. If he had done that, he would have enlarged this also and enlarged into here a little bit also. Now, nickel titanium instruments. They are a tremendous advancement over stainless steel. They're much more flexible, much more resistant to cyclic fatigue. And if you use them in a torque control handpiece, this is to give you a comfort level that you won't separate the instrument. And if you push too hard, it will go into reverse for about a turn, releasing the pressure, and then it'll start turning again. Torque control handpieces are analogous to training wheels on a bicycle. When you have a young kid who's learning to ride a bicycle, you'll put training wheels on it. And he gets on it and he kind of wobbles, but he goes straight and he doesn't fall off of it. But once he's doing a good job of riding straight with training wheels and he tries to turn, well, they keep him from turning efficiently. So the next point is take the training wheels off and let him learn how to make his turns and do well. Training wheels are good for protection when you're learning, but they're a hindrance to you once you master riding the bicycle. Torque control handpieces are good when you're learning, but they hinder your ability to use the instruments to their maximum. And if you keep using torque control and keep pushing on it, and it reverses and goes forward and push again, reverses, goes forward, this backwards and forwards motion of these instruments, because they're so flexible, they will twist when you're doing this, and this twisting action results in cyclic fatigue fractures in the depths of the flutes, as is illustrated there. This is a study that was published in the Journal of Endodontics in 2004. You don't want that happening. In fact, that repeated process will decrease the life of these instruments by about 60%. Now, they came up with another point in this article, is the need for high metallurgical quality of the nickel titanium alloy. I invented rotary nickel titanium instruments greater than O2 taper. I thought nickel titanium was nickel titanium. You may think stainless steel is stainless steel. There are over 450 different formulations for stainless steel. There are different grades of nickel titanium, and we're going to get into that. But I didn't really think about that until I saw this quote. And then I asked the engineer who draws the nickel titanium wire for us. I said, Carl, are there different grades of nickel titanium? And as most engineers do, he gave me a very technical answer. I said, just answer it yes or no. He said, yes, Ben, there are different grades of it. You're using the highest grade. So there are different grades of it. And they went on to say electropolishing to minimize the surface machining damage might help the instruments, because we know that when an instrument separates, that crack always begins in a machining groove. Always begins in a machining groove. And then they talked about another promising approach is the use of ion implantation into the nickel titanium metal. You could use boron, you could use titanium nitride. There's all sorts of coatings that you can do. So I started investigating how can you improve what we're doing now. Here's another article that was published in the Journal of Endodontics in 2004 comparing 3 different types of nickel titanium instruments. No, not this one. This one is talking about fractures and tissue being embedded in the fractures. And here is a beginning fracture, and you can see tissue kind of stuck into it, hanging off of it. Here you can see it stuck in this fracture. Here's another photograph showing debris caught in this crack, and you can see debris here where the instrument fractured. Now, they concluded that this dentin debris in these beginning fractures may help potentiate these fractures. Well, this debris will act as a wedge, that's true, and wedges will potentiate cracks, but I don't know if it's that significant, because I think if this instrument was left to rotate another 4 or 5 turns, it would have broken without the debris in it anyway. But it does point out that multiple use of these instruments, if you do that, it's very difficult, impossible to get this debris out of there. Sodium hypochlorite will not dissolve it out, and sodium hypochlorite will hurt the endodontic instrument to begin with. But at any rate, just to show you the research that has been done here. Here's another one where they're comparing 3 instruments and their ability to instrument canals. This is the race instrument, which is an active cutting blade, and you can see they didn't take it all the way to the terminus of the canal, as I advocate, but nonetheless, that's what they were striving for. Their goal was to prepare these S-shaped plastic blocks to a size 3006 taper. And here's a K3 3006. You can see it's a bigger preparation than this one, and because K3 is a little stiffer, it will cause some transportation. And here's a Pro Taper Finisher 3. Now the Finisher 3 is a 3009 taper. It's not a 3006 taper. Now, why would they use a 3009 taper when their goal is to prepare a 3006 preparation? It makes no sense. In fact, I think they did it in order to make Densply's product look inferior, because this does not look good. But I would never have tried to go around 2 curves with a 3009 taper clinically anyway. If they wanted to use an instrument to accomplish the goals they set out, they should have used a profile, or a Profile GT 30 series, where they could have had a 3006 to prepare it. But I think they just wanted to make those instruments look bad, when that's okay with me, because I wouldn't use them in that situation anyway. They did in the article talk about it had a greater taper size, which probably made it look worse. Now, we're going to get into a very detailed discussion of the instruments that you can buy. And we're going to get into a very detailed discussion of why instruments separate. And these are things that I want you to keep in mind. The surface texture. And when I say surface texture, the roughness of the grinding technique. How rough does this instrument appear? How smooth does it appear? Because cracks always form in a machining groove. The tip of the instrument. Does it look like it would follow a canal? Does it look like it pushed debris apically? The transition angle from the tip to the blade, is it a smooth transition or is it a sharp transition? The helical angle, these are the number of, this is the angle of the spiral on the instrument. Pitch, which is a difference between the flutes, I'm not even going to talk about it today. The cross-sectional shape of the instrument. This is very important, because when you cut across an instrument, what is the surface area you're looking at? If it's a large surface area of metal, this means cyclic fatigue will induce quickly. It means the instrument will be stiffer than one that has a smaller cross-sectional area. It also means it would have greater torque strength. These are all things that interrelate. The material. Of course, now we're talking about nickel titanium, and I'm going to show you the difference in the materials that the various manufacturers use. And the taper. The greater the taper, the greater the torque strength, the less flexible it is, the more susceptible to cyclic fatigue. And that's pretty much all I'm going to say about it. Now, here's a question. Which is most important in resistance to cyclic fatigue? Surface texture, cross-sectional shape, material, all of the above. This is like a test that you would take in grade school. If it says all of the above, check that. You're probably right. I used to think cross-sectional shape was the most important aspect. In other words, the surface area, how much metal there was. I no longer believe that. It is either the surface texture or the material, the quality of the material. Now, this is the K3 instrument. Quantech would look very similar. These are made by Cybron. This has a very nice shaped tip. It has a very rough surface grind. If you drew the circle around this, you can see that this has a large surface area of metal, which means it's susceptible to cyclic fatigue. It's not very flexible. It is extremely strong torque strength. When would you use an instrument like this? In a relatively straight canal or minor curvature would be a great instrument for using. Would it fracture easily? Yes, just because of the rough surface grind, if you exceed its stress limits. This is the profile instrument, nice tip, smooth transition at your transition angle. You see it's a smoother surface grind. Cross-sectional area, much less surface area here than on the K3. What does that mean? More resistant to cyclic fatigue, more flexible, less torque strength. This would be a good instrument for moderate curvature to severe curvature. Resistant to cyclic fatigue, torque strength is not as strong as K3. This is the ProTaper instrument, which is made in Switzerland. Smoother surface grind than the profile instrument. Flat tip, sharp transition angle, terrible tip design. Cross-sectional shape, it is a convex triangle. And if you look at the surface area, much more surface area than the profile, which means it's less resistant to cyclic fatigue. It is less flexible than the profile, except this instrument has multiple tapers on the same blade. So in the Shaper and Shaper 1 and Shaper 2 instrument, very flexible, last 4 or 5 millimeters because they are small, but cross-section for cross-section, stiffer. Greater torque strength. Smooth surface grind, so resistant to fracture. This is the Hero instrument, which is similar to, is the same thing as Guidance in the US. It's made by Micromega in Europe. Beautiful tip design, very smooth surface. That's because they electropolish these instruments. Cross-sectional area, large cross-sectional area, which means great torque strength, not very flexible, not very resistant to cyclic fatigue. A good instrument to use straight or mild curvatures. This is the Race instrument. Be very similar to Sequence, except Sequence is an isosceles triangle. It's not an equilateral triangle. Small surface area, which means flexible, resistant to cyclic fatigue, and not very much torque strength, but beautifully smooth surface because they electropolish these instruments. I went to the factory in January and looked at the instruments before they ground them, or right after they ground them. They do not use diamonds. I don't know what they use, but I've never seen this grinding pattern, and this is a very high magnification, about 300 magnification. And you'll see that the grind on this flute and the grind on this flute don't meet. So they have this little ridge. And then they electropolish them, and when they electropolish them, that brings these the ridges down to the depth of the groove. So it's very, very smooth, and it also produces a sharp cutting edge there. Very nice manufacturing. I'm not real happy with the blade design, but the quality of manufacturing is exceptional. This is the ProTaper instrument, 100 magnification, a 300 magnification, and you can see the roughness of the grind. In fact, you can see some pretty significant defects here. Horrible tip, as I've talked about, with sharp transition angles. Here they are after they're electropolished, rather smooth. Cutting edge is not as sharp as it was before, but that's okay with me because I don't like real sharp instruments anyway, because I don't like the transportation. And these are profiles that are produced in Europe, which is again a very rough surface grind in Europe, not in the US, but in Europe. And after they are electropolished, very, very smooth again. Now, you can take electropolishing to extremes. Here is a profile instrument that has been electropolished too much. It is so smooth that you no longer have cutting edges. It wouldn't do anything for you in the mouth, but it is very smooth. There's another way of producing a smoother instrument, and that's by coating it, or ion implantation. But nitride coatings fill in the depths of the grooves. They don't wear down the top part of a groove, but they fill in the depths. And this will make an instrument last a lot longer because it kind of puts a protective coating over the inner nickel titanium. The problem with it is it has to be perfect, because if you have a defect, all of the stresses in the nickel titanium under this are centered in that one point, and these will actually fracture faster than they would if they were uncoated. So if you do a nitride coating, it has to be done perfectly. So far, no instruments are manufactured this way. I have been working with a Russian physicist who now lives in Montana, and he has perfected a way of doing this coatings where it doesn't have defects. So you may well see some of these instruments on the market in the next year or two. Now, I was giving you visually surface roughness from scanning electron microscopes. Here's another one that was published in the Journal of Endodontics in 2005. Quantec versus GT rotary versus GT hand versus NiTiflex. And of course, this is Quantec. K3 would have been similar. They're made on the same machines. Very rough surface grind. The Dentsply instruments made in the US, not as bad. The instruments made by Dentsply in Europe, much smoother. If they had done Hero instruments or sequence instruments, they would have been smoother still because they are electropolished. This is showing you graphically the surface grind of the instruments, and we'll make this relevant to you later on. And which tip design would be more appropriate? I think this is a horrible tip design. This would be a much better tip design. I did this in my operatory by just rotating a ProTaper instrument on a diamond deb, and if I can do that in my operatory, I know they can machine that in their factories, so they need to do that to improve the tip design. Now, before I go farther, I want to read you something that someone emailed me. And if you, well, you probably get jokes emailed to you periodically. Everybody does and shares them. This one isn't so much a joke as it is a story that happens to be true. And I want to share it with you. The U.S. standard railroad gauge, the distance between the rails, is 4 feet 8.5 inches. Now that's an exceedingly odd number. Why was that gauge used? Because that's the way they built them in England, and the English expatriates built the U.S. railroads. Why did the English build them like that? Because the first rail lines were built by the same people who built the pre-railroad tramways, and that's the gauge they used. Why did they use that gauge then? Because the people who built the tramways used the same jigs and tools that they used for building wagons, which used that wheel spacing. Why did the wagons have that particular odd wheel spacing? Because if they tried to use any other spacing, the wagon wheels would break on some of the old long-distance roads in England, because that was the spacing of the wheel ruts. So who built those old rutted roads? Imperial Rome built the first long-distance roads in Europe for their legions, and the roads have been used ever since. And the ruts in the roads? Roman war chariots formed the initial ruts, which everyone else had to match for fear of destroying their wagon wheels. Since the chariots were made for Imperial Rome, they were all alike in the manner of wheel spacing. The United States railroad gauge of 4 feet 8.5 inches is derived from the original specifications for Imperial Roman war chariots. And bureaucracies live forever. So the next time you are handed a specification and told, "We have always done it that way," and wonder what horse's ass came up with that, you may be exactly right, because the Imperial Roman war chariots were made just wide enough to accommodate the back end of 2 war horses. Now the twist of the story. A space shuttle sitting on its launch pad has 2 big booster rockets attached to the side of the main fuel tank. These are solid rocket boosters, or SRBs. The SRBs are made by Thiokol at their factory in Utah. The engineers who designed the SRBs would have preferred to have made them a bit fatter, but they had to be shipped by train from the factory to the launch site. The railroad line from the factory happens to run through a tunnel in the mountains, and the SRBs had to fit through that tunnel. The tunnel is slightly wider than the railroad track, and the railroad track, as you know by now, is about as wide as 2 horses' behinds. So a major space shuttle design feature of what is arguably the world's most advanced transportation system was determined over 2,000 years ago by the width of a horse's ass. And you thought being a horse's ass wasn't important. Now, I share this story with you because oftentimes what we do in endodontics, we do because it's always been done that way. Now, when it came to designing a nickel titanium instrument, I called up the manufacturer and I said, "Derek, I want you to make a U-fluted instrument out of nickel titanium, and I want you to double the taper." And that's what he did. Instead of the sharp edges, he made radial lands. He used the same number of spirals that had always been used. He used the same helical angle that has always been used. But what if you change that helical angle? Will it work differently? I know it will work differently. Here you can see that I've changed the helical angle at the tip and the mid-root, kept it the same here. I don't think that would be a great improvement, but if you did it the other way and changed the helical angle up here and made it tighter at the tip, I think this would be a great improvement. Because if you've used rotary nickel titanium instruments, you know when you reach a particular size, it kind of pulls you into the canal. And if you lowered this helical angle back here, it would slip on the dentin and cut the dentin without engaging it and working like a screw and pulling you into the canal. So I think this would be a tremendous improvement. And no one's done it. Now, we talked about cross-sectional surface area. Here is a circular shaft that is approximately the same diameter as the depth of these flutes. and I had this instrument made specially. It's a parallel instrument, U-flute design, and I'm going to ask you which one of these is more resistant to cyclic fatigue. In other words, when I rotate this around a curve, which is going to fracture soonest, this circular shaft or this bigger instrument? I thought that the larger instrument would fracture first, but it didn't. This instrument lasted longer than this one did. This makes no sense to me because I know a circular shaft that is smaller in cross-sectional area should rotate longer. And so I took some scanning electron micrographs to look at it, and indeed, here's the problem. The grinding techniques that they used to manufacture this circular parallel shaft was not very good. You can see the machining defects, and as this is compressed and stretched, this induces cyclic fatigue faster than the machining processes on this instrument. So this is telling me that the machining quality is very important, more important than the cross-sectional shape. Now, here are cross-sectional shapes that we encounter in endodontics. This is the pro-taper, which is a convex triangle, greater surface area. This is the old Onyx R, which is a concave triangle. Did I say concave before or convex? Pro-taper is a convex. This is a concave. This would be very flexible. It'd be highly resistant to cyclic fatigue, but it does not have much torque strength. So, interestingly enough, I don't even think they make this instrument anymore because it fractured so frequently with increases in torque. This is the hero instrument, or the guidance instrument. It starts with a triangle and just kind of does the tip a little bit like a wave on the ocean. It's a well-machined instrument. We know it's smooth surface grind, has a pretty large surface area, high torque strength, little stiffer than some of the other designs. This is the sequence instrument, which is an isosceles triangle. They talk about alternating points of contact. It doesn't have alternating points of contact, but when you hold the instrument up, it looks that way because each blade that comes around is in a different position. And interestingly enough, the center core, as you would come out this shaft, this center core keeps changing. It keeps changing. Now, it's a well-manufactured instrument, very smooth surface area, very smooth surface. Not such a large surface area, so it's very flexible, but I suspect this center core being located in different spots, the stresses would not be distributed evenly, and I suspect that even though the cross-sectional area is not large, and even though the machining quality is excellent, I think that this uneven distribution of forces would lead to early cyclic fatigue failure. I don't know that, I suspect it. And you could have something like this with the edges on it. This is what the finisher number 3 looks like. Not quite that deep of flutes, but an attempt to give it some flexibility, which did not work. This is the K3 instrument, which is large surface area, passive cutting blades, rough surface grind, high torque strength, not very resistant to cyclic fatigue. This is the U-file blade design that's on the profile instruments, the rotary GTs, the light speed instruments. And you can make those grooves deeper to give it more flexibility. You can make them exceedingly deep so that they're exceedingly flexible. In fact, you can do that all on one shaft. You could have this at the tip of the root, mid-root, upper portions of the canal where the diameters are getting greater, and maintain flexibility. When these instruments were first introduced in 1994, that's exactly how they were made. And you'll see it working. The tip is not transporting at all, it's not cutting at all, but this 04 taper, when it engages the tooth structure, in this case the plastic block, it starts to cut, and it cuts until it moves apically, and the apical tip is engaged and it ceases to cut. You can see that when you overstress the instrument, overstress it torque-wise, instead of separating, it starts to unwind and actually wind up in reverse. Without fracturing, because the stresses are distributed pretty evenly because that inner core remains parallel. And you'll see when it deforms and starts to unwind, when it winds up in reverse, the diameter actually narrows, releasing the instrument from contact with tooth structure. See how narrow that is compared to what it really was to begin with? In fact, when you took this instrument out, it had more twist in reverse than it had to begin with. So very resistant to fracture because you exceeded the when you exceeded the torque limits of the instruments. Now, in 1994, when you went from stainless steel instruments to rotary nickel titanium instruments, the price went from $6 to $35. Ooh, this is a big difference in price. But very, very flexible, created a crown down preparation automatically. What was the biggest complaint that people who purchased this instrument had? They didn't like it unwinding. They paid a lot of money for it, and when they used it, they didn't like it to unwind. Can you fix that? Sure, you can fix it. You just don't make the grooves deeper as you come up the shaft. And instead of unwinding, it'll distort a little bit, and then when you exceed the torque limits, it will break. And that's what happens today with rotary nickel titanium instruments. None of them have this design. And they all have adequate torque strength, but when you exceed that torque strength, you no longer have this safety factor. So be careful what you ask for. You may get it. And I think that this might be a good design to reintroduce into instruments, particularly for very curved canals. Okay, at this point in time, we have gone through the instruments that are available on the marketplace. We've looked at the surface roughness of the grind. We've looked at the cross-sectional surface areas. You should be able to determine, does an instrument have high torque strength? Does it have great flexibility? Is it resistant to cyclic fatigue? And you've, of course, if you haven't thought about it, you have found out that flexibility and resistance to cyclic fatigue, the more flexible it is, the more resistant to cyclic fatigue, and the stiffer it is, the greater torque strength it has. And then, of course, the grind, the surface grind, has something to do with the cyclic fatigue also. Now, going back to the U-file blade design that you find on profiles and rotary GTs, there is a modification that can be done because many endodontists use the active cutting blades to create quick shape within the root canal system. And I like the Shaper 1 and the Shaper 2 instruments of ProTaper because they have very flexible small tips and they have increasing tapers as you come up the shaft, so it can enlarge the upper half of the canal very, very quickly with the Shaper 1. And then the Shaper 2 can come down into the canal and enlarge the junction of the apical third and the middle third, leaving the apical area to be enlarged. I love that instrument because it works so quickly and is so flexible. But once you've used Shaper 1 and Shaper 2, most of the endodontists that I know switch to a passive cutting blade, a radial landed instrument, in order to prepare the apex, because we don't want to create ledges and we don't want to transport the canal in the apical portion. That's very important, because remember, wherever you are transporting a canal, you're pushing debris into the other area, and we don't want debris in the root canal system. We want to clean it out. And this is an interesting design that a young man, a graduate student that I taught at Baylor University, his name is Andris Jabernsons. I can't spell the last name. I can barely pronounce it. He's from Latvia. But he came up with the idea of taking the U-file blade and just creating a little bevel on it. And by creating a small bevel, you make it semi-active. It will not cut any deeper than this, because this trailing edge will then hit the dentin, preventing it from going deeper. Or you can make it a very active blade by increasing that angle of the bevel. Now you can have instruments that are very active that go all the way to the apex, smaller sizes hopefully, and you can have semi-active instruments that you use next to do some enlarging, and then you can have totally passive blades. So you can have three sets of instruments: very active, semi-active, and passive. Or, which I'm more excited about this, you could have one blade, and at the tip you could have it passive, mid-root you could have it semi-active, and up in the upper area where delicacy is not important, you could have it very active. And you could put multiple tapers on this blade to create great enlarging in the coronal area, and just semi-active in the mid portion, and then totally passive at the tip. You could combine all of these instruments into one blade. Manufacturers haven't done that yet because they couldn't figure out how to transition from these triangular shaped blades to these radial landed blades, and by doing it this way you're able to do it very, very easily and efficiently. However, there is one detriment for manufacturers to do this, because at the present time they sell you two systems, an active system and a passive system. So you're buying more instruments. This way you would be buying fewer instruments. And manufacturers, of course, like to sell products. So whether they will do this or not, I don't know. But I will be informing the manufacturers about this in the coming months. I think it's a wonderful idea. And particularly, as I said earlier, if you decrease this helical angle in the upper portion, I think it'll work very, very efficiently and very effectively. So there is another instrument design that has been brought to my attention by some of my Italian friends. And if you took this radial land and just cut it right here and cut it right there, you could move the tip of the instrument from this point, which would make it very active, over to the back edge, which would make it passive. So it can be done different ways, but the same concept. Nickel titanium. As I mentioned earlier, there are different qualities of nickel titanium. And a young graduate student from University of Virginia gave this presentation at the American Association of Endodontists meeting last month. And it's a very simple experiment, but she wanted to see if the immersion time in sodium hypochlorite affected cyclic fatigue. We know that it does because other research has been done along these lines, and her results showed that with both file types, and she was testing K3 versus profiles, A decrease in the time to fracture was noted with an increase in the immersion time of sodium hypochlorite. And profiles responded better in every time compared to K3, but you should know that already because of the surface grind and the cross-sectional areas. You would expect that. Now, what she did was take these instruments and put them into test tubes with the sodium hypochlorite in the test tubes. And here's 5 minutes. Here's the profile, and here's the K3. Notice the bubbles on the surface of the K3. Something is starting to happen. And at 10 minutes, or 1 hour, if you look closely, you can see some little black particles floating on the surface of the solution here, and you see more bubbles occurring here. And if you look closely, it's just a little darker solution than you find on the profile. At 2 hours' time, you can see the solution is considerably darker. And also, you'll notice something is starting to happen on the profile instruments. Now, I think as a graduate student, she was more concerned about corrosion of these instruments and it affecting the life of the nickel titanium instruments. But in fact, we don't keep these instruments immersed in sodium hypochlorite, so that's not necessarily a bad thing. We certainly don't use it that way for an hour. But I think it's important because it shows you the difference in the quality of the nickel titanium that's used in the various instruments. K3 on the instrument before it's immersed, you'll see some defects already present. Of course, after 2 hours immersion, you see the defects going deep into the metal. On the profiles, no defects. And after 2 hours of immersion, you see some small areas developing. Here's another article that was published in 2003, and it has the Quantec instruments are the instruments that are labeled A, and profiles are the instruments B. GTs are the instrument C, and light speeds are the instrument D. And you can see that some of the Quantec instruments, which would be similar to K3, they're manufactured out of the same material at the same factory. Some of them just literally corroded off. Where the profiles and the GTs lasted very well, you see some corrosion on the handles. The handles should not have been immersed. But this is a previous study. Here's another study that was done by Peters that will be published soon, again comparing race files with profiles, and again talking about cyclic fatigue, lots of graphs that mean very little to us. But just to look at what, if you leave this in solution for 24 hours, the race instruments almost disappear from the corrosion. The profiles, of course, after 24 hours showed some signs of corrosion, but not to this extent. So there is a large difference in the quality of metals. In fact, the metal that is used to produce the instruments in the U.S. is made, and in Europe for that matter, is made from NDC is the name of the company, and type 508 nickel titanium. This is the purest form of nickel titanium. Now, I will give you one suggestion for clinical use. This particular type of nickel titanium has the least impurities of any manufacturer of nickel titanium, and there's only 5 or 6 in the world, so there are not very many areas that companies that make nickel titanium. And when it's made, it is put into cables about the diameter of my thumb, and then they send it to various processors, and they draw this down into smaller and smaller diameters to the diameter that is appropriate for machining an instrument. Carbon impurities never break down in size, and they're of magnitude of 11 to 15 microns, not very large, but once it comes from a big cable into a smaller wire and a smaller wire and a smaller wire, and then this wire is ground into a size 15 instrument, that very small carbon fiber, if it happens to be, or carbon particle, if it happens to be at the tip of an instrument, that tip can break spontaneously. So before you use a nickel titanium instrument, just take it and bend the tip back and forth. If it doesn't break, then you don't have a problem. Instrumentation possibilities as far as the materials go. This is a testing machine to test cyclic fatigue of the raw materials. The outside rod is a material that the instruments in Europe are made from by Dentsply, Meifer. The center rod is the one that the instruments in the U.S. are made by Dentsply Tulsa. And the rod on the inside is this new method of drawing the wire, nickel titanium wire. And I want you to see the cyclic fatigue resistance of these various metals. This is an extremely taxing cyclic fatigue test because the rod is vibrating back and forth all the time. And you can see the one that they use in Europe fractures in 23 seconds. The one that's used in the manufacture of instruments by Dentsply in the U.S. fractures at 31 seconds. This new material lasts for 181 seconds. That's a tremendous increase in resistance to cyclic fatigue. Now, the reason for it is the way this material is drawn is it reduces the cold work that's done on these metals. And you can see the difference in amplitude from the one in Europe to the one in the U.S. to this new way of drawing the wire. It dampens this vibration effect. And when I say dampens, I don't mean wet. It attenuates this vibration of the metal. Now, these graphs don't mean much to you, except this is how nickel titanium works. At rest, it is in this form. When you put it under tension or a bending effect, it goes up in strain and it changes from austenite to martensite. And if you relieve the stress, it returns right back to its normal position. This is the superelastic portion of nickel titanium. If the stress is continued, you can see that it will actually stretch about 14%, and then it will break. Now, what's important for an endodontic instrument is the relationship of this upper plateau to the upper tensile strength. You divide the upper tensile strength by the upper plateau and you reach a ratio. Small increases in this ratio means the metal is much more suitable for nickel titanium instruments. And this is the flag. We call this a flag. It's just a laboratory examination of the instruments, of the raw wire. This is the flag of the material that's used in Europe at Meifer, very good nickel titanium. This is the flag that's used in the U.S. for their endodontic instruments, again, very good. You'll notice this number went up. And this is the flag of the new metal. And over here in the corner, you can see the differences. This is the European metal, the U.S. metal, and this is the new metal. And like I said, very small increases in this ratio produces an instrument much more resistant to cyclic fatigue. Cyclic fatigue of endodontic instruments, the way we measure them, is to put the instrument into a device that curves the instrument 90 degrees around a 5 millimeter radius, and then you rotate it until it fractures. Now, when we actually test this, we put a water spray on it to cool it to keep frictional heat from building up. Then you rotate it until it fractures. This tells you the resistance to cyclic fatigue. This particular one lasted 279 seconds. Now, this looks like a very simple chart, but it is somewhat complicated. And I want to tell you that the profile, these are all profile 04 instruments, size 25, tested at 300 revolutions per minute. There are 9 tests in each category, and the profile 04 taper instruments produced in the U.S. average about 140, 150 seconds. The reason they're not all the same is when you're grinding an instrument, after about every 200 to 300 instruments, you have to change the grinding wheel or redress it because it becomes rougher. And of course, the rougher the grind, then that will affect cyclic fatigue. This is the superior metal to the MIFR because this lasts 31 seconds versus 23 seconds. But as I showed you earlier on the scanning electron micrographs and that atomic force microscopy, this is a smoother grind. So the smoother grind, even though it's on a material that's 50% less resistant to cyclic fatigue, these instruments last longer, and an average time would be about 250 seconds, so approximately 100 seconds longer. So even though this is an inferior metal, the smoother surface grind produces an instrument that will last longer. This is the superior metal I just showed you ground on these machines. So you can see that the superior metal, if it is multiple times superior, even though it is a rough grind, will produce better instruments. If you had this smoother metal on a smoother grind, it would produce resistance to cyclic fatigue that would be off the chart. So this is what I'm trying to get manufacturers to do, is use this superior metal on a very smooth grinding procedure. And if FKG, which is the one that made the race and the sequence file that has the smoothest surface, if they would produce that smooth surface with a design that distributed stresses equally and made it out of this new metal, you would have instruments that would last 1,000, 1,500 seconds. So this is the way these things relate. Now, I've had some endodontists who've heard this lecture say, well, Ben, you're very critical of Dentsply. I'm not very critical of Dentsply. I've been telling Dentsply this for 5 years. But to get a manufacturer to change their manufacturing processes is not easy. But when you show them the efficacy of what can be produced, I am convinced that somebody will do it. And once somebody does it, then everybody will do it. Then you will have better instruments made out of better metal, and hopefully your patients have a better result. So this is what I am presently trying to accomplish. And to sum that up, I call this NiTi ESM, which is energetically stabilized martensite. It's 6 to 9 times more resistant to cyclic fatigue in the raw metal, and when it is ground with a intermediate roughness, it's 3 to 4 times more resistant to cyclic fatigue. And if it were ground, like I said, on FKG, on a very smooth surface, I think it would be 7 to 8 times more resistant to cyclic fatigue in a finished instrument. These are huge quantum leaps in quality for instruments that can be accomplished. Now, does the use of nickel titanium instruments improve endodontic success rates? There have actually been no studies to show this outside of university studies, which show that there is a decrease in the number of appointments necessary for students to complete a root canal. There are fewer procedural problems encountered, such as ledges and perforations. The quality, judging from the radiograph, the quality of work that the students do is superior. Will that result in a higher success rate? That's dependent upon the reduction of the number of bacteria and the ability to clean the root canal system. And once we get the ability to better clean these root canals and reduce the number of bacteria, yes, this will help you in having a higher success rate. But the use of nickel titanium itself compared to hand stainless steel at this point in time has not done that. Why? Well, as I said earlier, your obturation merely maintains the healthy environment that you create with your cleaning and shaping. Notice I say cleaning and shaping, because the use of instruments really creates convenience form for your irrigants to reach the root canal system and convenience form for you to obturate with. That's all your instruments do, is create convenience form. And it's a matter for you and the way you use these instruments by cleaning the canal afterward that will produce the healthier environment. This is why we talk about cleaning and shaping. You're shaping with instruments. Once you get this convenience form shape, then you do what you do for increased cleaning, such as using a pre-curved hand instrument to dislodge this debris that's forced into these ramifications of the root canal and bring them into suspension so that you can irrigate it out. And irrigation is a very important part. And we talked about BioPure or MTA earlier, removing the smear layer and killing bacteria. So that is what produces increased success rate. Now, there was a very important article published, I think it was in February of 2005, from the Ohio State University. And it went pretty much unnoticed, but it was not unnoticed by me. In fact, I had talked to some of these researchers the previous 6 months, and I went to Ohio State and I saw what they were doing and went back to Dentsply and told them, you should license this technology because I think this is excellent. And unfortunately, they did not, but maybe fortunately for me, they didn't, because I'm going to take this and make it a commercial product. Now, what they tried to do was clean and shape root canals using hand rotary technique, and then use ultrasonic irrigation to see if it improved it. And of course, the goal of instrumentation is the removal of all vital or necrotic tissue, microorganisms, and their byproducts. And the intricate nature of canals and isthmuses complicates cleaning. We know this. I've demonstrated it to you. Now, portions of the canal and isthmuses areas are inaccessible to hand and rotary instrumentation. And here are numerous articles that talk about that. We cannot get to these spaces with our instruments. Ultrasonic instrumentation alone has not resulted in better canal debridement. There's numerous articles that talk about that. And ultrasound used after hand instrumentation, yes, some better canal and isthmus cleanliness, but not totally clean by any means. And there's numerous articles that have been published on this. And of course, you can have file breakage. And your debris removal has not been greatly improved because your irrigation is confined to the coronal portion of the root canal when you're ultrasonically activating these files, and you can produce canal transportation during the process. So what these gentlemen did, I thought, was very innovative in a minor way, but with major results. They took a syringe, this is a 30 cc syringe, connected it by flexible tubing to a lure lock syringe. This happened to be a size 25 gauge needle. And then they took an ultrasonic file adapter and by use of a laser drilled a hole through this piece, and it inserted the ultrasonic file through here, tightened that locking nut so that ultrasonic energy could be delivered to this needle. And while they were ultrasonically energizing the fluid in the canal, they irrigated sodium hypochlorite. And I'll go through this. And then they extracted the teeth. This was done on live patients. They extracted the teeth then did his histologic sections to compare the efficacy. They used a hand rotary technique, and then they used a hand rotary technique with 1 minute of ultrasonic irrigation. They did this on the mesial roots of mandibular molars. They did it on live patients, and these molars had vital tissue. Vital tissue is much more difficult for sodium hypochlorite to dissolve than necrotic tissue. Necrotic tissue is dissolved very quickly by sodium hypochlorite. Live tissue is not. And after they did this, as I said, they extracted these teeth. Now, the way they did it, they determined the working length using an apex locator, radiographically with hand files, and they determined the working length to be about 1 millimeter from the apex. This is pretty close to the terminus of the root canal. They used hand files to scout the canals first, and then they followed that with Profile GT 30 series instruments, and they did this during the instrumentation process and irrigated with sodium hypochlorite. They enlarged each canal to a size 30. These are the teeth that they did only by hand rotary technique. For the hand rotary and ultrasonic technique, they did the same preparation, irrigating with sodium hypochlorite. Then they came back with the ultrasonically activated needle, which was a 25 gauge needle, which is not very small. And they used full power on the ultrasonic unit. They used an EMS unit. And they used 30 cc's of full strength sodium hypochlorite. And the needle was placed in the canal without pre-bending it, which means it just went to the top of the mid-root curve. That's as far as it went apically. Used 1 minute of ultrasonic irrigation with 30 cc's of sodium hypochlorite. And the teeth, once they were extracted, they found out that no difference in curvatures, there was equal distribution, and no difference in the root typing as which ones had isthmuses and whatnot, or curvature. So all very similar. And once they were extracted, oops, I want to go back to that. Once they were extracted, they did sections at every 0.2 millimeters. Now you can see once they got 3 millimeters away from the apex, the ultrasonics provided no increased cleaning efficacy in the canal. And that's not surprising because 3 millimeters back, this size 30 06 taper is now a size 48. And a size 48 is a pretty substantial file size. So from 3 millimeters coronally, hand rotary was as good as hand rotary plus ultrasonics. But apically, you'll notice that 1 minute of ultrasonic irrigation makes the canals considerably cleaner, and it averaged 99 point something or other. So 99% clean on the apical 2 millimeters, 2.2 millimeters. That's a significant improvement in canal cleanliness. On the isthmus cleanliness, not surprising, the hand rotary didn't do very good because these instruments don't get into the isthmuses. They have no way of helping the sodium hypochlorite clean out this area. But 1 minute of ultrasonics worked very well. And you'll notice in the apical area, it worked better than anywhere else. And I'm going to explain that in a moment. Now, as it relates to isthmus cleanliness and the curvature, this is somewhat surprising to me, or was surprising. If it was a moderate curvature, ultrasonics certainly work better than hand rotary, as you would expect. But notice again, much superior in the apical 1.5 millimeters compared to the rest of it going up to 3 millimeters. In severe curvature, it worked a lot better than hand rotary. In fact, in severe curvature, it generally worked better than in moderate curvature. Now, I was somewhat perplexed by this, and I had these printouts on pages of paper because even though I'm doing this presentation on a computer, I am computer illiterate. So they gave it to me in a hand on paper. So I was going through this by hand when I was sitting on the airplane. And the gentleman sitting next to me was looking at this, and he said, "Oh, that's very interesting." And I looked at him and I said, are you a dentist? And he said, "No, I'm a petroleum engineer. I'm a flow rheologist." And I said, "What is that?" He said, "I study the flow of liquids in closed systems." And I said, "Well, can you explain this ultrasonic irrigation to me? Why does it work better in a severe curvature than a moderate curvature?" And he said, "This is very simple." He said, "These ultrasonic energy that's delivered to this fluid," and he asked me, "Is that 25,000 kilohertz or megahertz or however you measure it?" And I said, "Yeah, it's 25 to 30,000 somethings," because I don't pay attention to that. And he said, "Well, if it's a straight tube," he said, "all of these vibrations produce linear waves. It's just a linear wave, like a pulse coming at it." He said, "Once you're in a moderate curvature, this linear wave eventually hits the opposing wall and then it starts bouncing. This is why your cleanliness in the apical portion of a moderate curvature is better in the apical portion than it is in the other portions, is because these waves are bouncing back and forth through the canal, and that action produces better cleaning. That's also why in severe curvature you have better cleaning, because it starts bouncing sooner." Now that sounded wonderful to me. I don't know if it's true or not, but that's the explanation he gave me, and it's certainly what they found. And here's a histologic sample. This is a tooth that has not been instrumented, 1 millimeter from the apex. Here's a canal, here's a canal, and this well may be a third canal in the mesial root of a lower molar that they didn't find. Or it could just be the configuration of the isthmus. Now, here is a hand rotary technique, 1 millimeter from the apex. This canal is 95% clean. And maybe as the instrument was rotating, it grabbed some of that tissue and it tore it out. Over here you can see where the instrument was rotating. And as I have said repeatedly, where an instrument doesn't touch, it pushes debris into that area. And this is 1 millimeter from the apex of hand rotary technique with sodium hypochlorite as an irrigant. But look at all the debris in the isthmus. This is at the 1 millimeter level with hand rotary instrumentation and 1 minute of ultrasonic irrigation. This canal is 100% clean, this canal is 100% clean, and this isthmus is 99.8% clean. This is a huge, huge improvement in removing tissue, which means now that your irrigants can reach the bacteria. And if you remove the smear layer by using BioPure or EDTA, BioPure in and of itself will sterilize dentin. You can now, using something like this, once you've completed your instrumentation, sterilize the root canal system and fill it all in one visit with more predictability than sealing intracanal medicaments in their inter-appointment. Now then, at the 3 millimeter level with hand rotary, you've got a rather circular prep, and your irrigation needles can reach deeper, and you have 100% clean here, 100% clean here, but only 51% clean in the isthmus. Big problem. With your hand rotary technique with 1 minute of ultrasonics at the 3 millimeter level, the canal is 100% clean, 100% clean, and the isthmus is now 90% clean. Again, a huge improvement. And their conclusion was the addition of 1 minute of ultrasonically activated irrigation significantly improved the mean canal and isthmus cleanliness value when compared to hand rotary technique alone. Now, if we can turn the lights down, I want you to see this, because once I saw this technique developed, can you all turn the lights down? Thank you. I got a gusto malantaka to get me 3 teeth that mesial roots of lower, this one happens to be a mesial buccal root of an upper molar, and the canal apex is curving toward the microscope, and this is the MB1, this is the MB2, and you can see all of the isthmuses going between these canals. We used our rotary nickel titanium instruments, and we established patency because Augusto Malantaka was there, Giuseppe Cantatori, and myself. Augusto was using the hand pieces, Giuseppe was pushing on the syringe, and I was the art director, keeping the slide under the microscope and changing magnifications. Instead of doing it like Ohio State did it, I used a 25 gauge needle, a 28 gauge needle, and a 30 gauge needle. We used only 10 cc's of sodium hypochlorite. We pre-curved the needle, much as we would do clinically, and then we used ultrasonic irrigation for the length of time it took us to clean it, because we're looking at this, and the maximum amount of time it took us was 7 minutes, the minimum amount of time was 5 minutes. And this is a 30 gauge needle. A 30 gauge needle with a safe end on it was totally ineffective, so we cut off the safety end to it. And you can see how clean it's getting here. You see this one piece of debris that came out of this isthmus into this canal, and we move it out and we move it in, move it out, move it in. But you have to know that 3 endodontists working under a microscope, we're going to get this as clean as possible. Compare this to what we did 2 years ago with hand rotary and our normal irrigation. You saw that this morning. And so we're working on this and working on it, and this piece of debris is going to come out of here before we quit. And sure enough, here shortly you'll see it just come up the other canal. There it goes. Once we had the canal cleaned, we filled the canal with dye, and you can see where your hand rotary went, but look at all these other areas that are totally cleaned of tissue. Now you have a situation where your inter-appointment medicaments will work, or you can come in there with BioPure, remove the smear layer, and sterilize it all in one visit. But when you get techniques like this available on the marketplace, the cases that you do are going to be much better. Here's another tooth we did with a large lateral canal and 2 accessory canals apically. We're going to do the same technique. We establish patency, and we're going to irrigate this to see if we can get tissue coming out of accessory canals. Here's our rotary instrument coming in. Here's your normal irrigation that you'll use with just a syringe, the way you normally irrigate, and you notice it doesn't clean any more than about 2 millimeters in advance of the needle. We pre-curve a hand instrument trying to get into these accessory canals, and we couldn't. Spent quite a few seconds trying to get into this accessory canal, and notice the coloration of the dentin. Augusto was pretty sure that this lateral canal was calcified and we couldn't get into it. So we attached a file to an ultrasonic instrument, and we came in and we ultrasonically activated this, trying to open up this accessory canal. And this is what we were looking at. Now you'll notice with an ultrasonic file, you are actively moving debris in the root canal system. It's not coming out because irrigants can't go in there, but it's putting the debris in suspension, so when you take the file out, you come back and irrigate, and it'll be much cleaner. But we're not able to get a file in there, so we came back with our ultrasonically activated needle and irrigation, and seeing how well we could clean this root canal system. And when we put it under high power, which will happen here in just a minute, we saw something amazing. Notice the tissue is being dislodged in the lateral canal. Can you see the tissue movement? And to me, it doesn't look like a chemical dissolving action. It looks more like a physical movement of the tissue. And we worked on this lateral canal for about 1.5 minutes, got it cleaned halfway up the lateral canal. And we decided, okay, we're not getting much tissue movement now. Let's go down and clean the apical portion. So when we went down to clean the apical portion, so you don't see much tissue movement now. When we went down to clean the apical portion, it was already clean. Our needle was nowhere close to this area, but the tissue was already removed from these accessory canals. This little white stuff that you see now is just bubbles caught in the lateral canals. We worked there for about 1.5 minutes. And then we moved back up to the lateral canal. And when we move back to the lateral canal, you'll see that the lateral canal is completely clean. There's no tissue left in the lateral canal. This tissue is stuck on the superglue at the surface of the tooth. And when we went back in with our pre-curved instrument, we could enter this canal now. So this, for 3 endodontists, is better than watching the Super Bowl on television, or the World Series in baseball, or maybe even a pornographic movie. This was very exciting for 3 endodontists to see tissue coming out of accessory canals. We stopped, had a cup of coffee, and discussed what we had seen. Now, we had established patency on both of these teeth, and there is some criticisms in literature that when a canal is patent, maybe the fluid going through the terminus of the canal might create an effect that is more cleansing than if the canal were closed off. So we decided to do one more tooth where the canal was not patent. So we got this lower molar. If you turn the lights back down again, we got this lower molar that again had an isthmus toward the apex between the 2 main canals and 2 apical openings. And we instrumented only to this point. We didn't try and move apically. And you'll notice your rotary nickel titanium instruments really don't clean that well on the inside of some of these curvatures because the tip is going down the outside portion of the curve. We instrumented these canals to a size 30-06 taper. The first root we did was only a 25-06 taper because it had a severe curvature. And once we had them instrumented down to the junction, then we came in with our ultrasonically activated needle, and we used a size 28 gauge needle principally, pre-curved. I don't think we used a 30 gauge needle on this because we didn't think 30 gauge needle was doing very well. Now I want you to watch this tissue as we're irrigating it ultrasonically. You'll see big pieces of it break off. See that tear off? And in just a little while, you'll see solution actually coming back up this other canal because it has created a pathway through here. You'll also see that tissue is already starting to come out of this apical opening. Can you see this pretty clearly? And you see fluid coming out the apex over here. This canal is already pretty clean. Move into the other canal, irrigate. You see this tissue start to move. You see fluid coming back up this canal when you're in that canal, vice versa. And once we have it as clean as we think we can get it, which was about 5 minutes of irrigation, we fill the canal with dye again to see the ramifications. You can see this little loop that we didn't know was there. Here's another loop, and all of the tissue out of the foramen and out of the isthmus. All of this done with 5 minutes of irrigation. You can turn the lights back up again. Now, once we are able to employ these irrigation techniques along with our rotary instrumentation techniques, we are now getting the canals about as clean as you can get them. And of course, once the tissue is out of the root canal system, then you can sterilize the root canal with whichever medicament you choose. Now, you noticed a great deal of fluid coming out the apices, and of course, no one wants sodium hypochlorite to come out of the apices of canals while you're irrigating. Keep in mind, this demonstration was done on extracted teeth. The studies that were done at Ohio State were on live patients sitting in the chair with vital pulps, and with a tooth that is in the mouth, you have the periodontal ligament going around the end of the root on a vital tooth, and on a necrotic tooth you have granulation tissue there. All of these things create a back pressure, and fluids in a canal always take the path of least resistance, which is back up the wider canal, not out the apex, as long as you have some sort of barrier present. And what you saw occurring on these videotapes was pretty much a physical dissolution of the pulp tissue. I didn't think it was chemical. So it may well be that something else could be used, such as Sterilox or sterile saline. Something like this may be as effective at removing this tissue. In fact, in cataract surgery now, it's the use has increased dramatically over the last 3 or 4 years. To remove the lens of an eye, they use pulse water to dissolve the lens of an eye or to break it up. So pulsed water has been done in other parts of the body. It may well work here instead of sodium hypochlorite. Whether it's sodium hypochlorite or water, at any rate, you have seen tremendous removal of tissue from the root canal system, greatly enhancing our cleaning effect. So I think this will be a significant advancement to endodontics. We've already, I think, talked about this particular part. Are there any questions about what you've just seen? To clearing the teeth? This is a technique that Dr. Malantaka in Rome, Italy has developed. Basically, to describe it, he takes a diamond disc and thins the root on both sides of the canal until he gets it very thin. Then he clears the teeth so that it's transparent, and then with chemicals he re-hardens it. He mounts it on a specimen slide, a glass slide with super glue, and then the areas that he thinned, he builds them up with super glue so that they have some thickness again. And this enables you to see the complications of anatomy that you encounter in tooth structure. He developed this technique for teaching students, but it also allows you to work on a tooth and see what's happening. He has written this up in an Italian journal. If you would like to have a translation of it, I can find it. I can get you one if you email me. My email address is bjohnson@tulsaendo.us. bjohnson@tulsaendo.us. Now I just want to have some fun with you about clinical cases. I've been practicing endodontics since 1973, and I sold my practice about 2 years ago. So I don't actually do clinical endodontics now, except when I'm in graduate school working with graduate students. But during my practice career, I've used many different techniques, lateral condensation, vertical compaction of warm gutta percha. I developed thermofill. I used large cleaning and shaping techniques to make large preparations. I've made very small preparations. I've been through the gambit. Now, we talked this morning about where do you want to be, short, flush, or long. These are 2 teeth that I did in the same week. And this particular upper lateral incisor, which had a significant lesion, and you see the curvature, and you know that it doesn't just curve distally, it curves palatally. We know this. And I instrumented to what I thought was the appropriate point at this point in my life, a little bit short of the apex. And this was my working length x-ray. I extended my length about 3/4 of a millimeter and then obturated the tooth, and my obturation doesn't appear to be going any deeper or any further apically. What it's doing is going palatally. But anyway, the patient came back in 6 months, and the lesion has not healed. In fact, it's getting larger because I was trying to stay within tooth structure the same way I was taught in school. So then we did surgery on the tooth, and then 6 months later you can see the lesion starting to resolve itself. The same week that I did that tooth, I did this tooth. And you can see there's some resorption at the apex, large lesion. I cleaned and shaped to this point and obturated to that point, but I got a large, and this is the largest I've ever had in my life, excess filling material. Here it is 20 years later, and it healed. Of course, I knew it was healing 6 months later when she came back in for her checkup appointment also. I decided at that point in time, if it's necrotic, I am cleaning to the terminus and I am filling to the terminus, because I had seen this in other cases. But these 2 cases that occurred in the same week made it obvious to me that it is the bacteria in this last millimeter that we haven't been cleaning out that has resulted in these failures. And it's as plain as a bee on your nose. It's as plain as the example I gave you earlier today about asking your patient. Anybody knows if you're doing a root canal, you want all of this debris and all of the bacteria out. And we know that sealers and gutta percha are relatively well tolerated by the body. I'm not saying I want it, but the body can tolerate it. And you know if it can tolerate it, because if you have something like you just saw a minute ago, oh gosh, excess sealer, gutta percha, oh, they're bound to have pain and discomfort, it's doomed for failure. That's not true. Because if it did fail and you took the tooth out and you put an implant in, now you have this big mass of metal sitting in the bone. The body will tolerate a lot. What it will not tolerate is bacteria. I'm old enough that I was taught if a lesion was extremely large and you had vertical mobility, endodontics was not possible. I was taught that if you had external root resorption, endodontics would not work. Now let me tell you something. Patients in dental school and patients in private practice are entirely different. Patients in dental schools do not have high expectations. Patients in private practice expect perfection. And they don't care if you say, this tooth can't be saved. They say, doctor, I want you to save this tooth. And here's a young lady. She was in her teenage years, and I could take my finger on this tooth and push down. I could push it in the socket 1.5 millimeters. I'd take my finger off, and it would come back into occlusion. And there's obviously root resorption has been going on. I told the mother, this tooth can't be saved. Oh, doctor, this is my daughter. Please save her tooth. Well, I will try. So I tried. And here's the instruments. Working length x-rays. You can see huge instruments. You can see all the root resorption that's present. You can see how it's resorbed this portion of the mesial root. And here's my obturation. And you can see sealer and gutta percha coming out into the bifurcation. I was not very optimistic about this. Here it is 6 months later. My philosophy is changing. If the bacteria are eliminated, the body will heal. And some endodontists like to think that they are superior to general practitioners. And we have had a lot more training, and maybe our hand skills are a little better, but I say only maybe, because here's a case done by a general practitioner. He found 2 canals, he instrumented 2 canals, and he obturated 3 portals of exit. This general practitioner had exceptional skills. Here's one who did this main canal, did a good job of irrigating, and here's another canal that he totally missed, but by using thermophil was able to obturate it. Is there tissue in that second canal? Probably. Is there tissue in the main canal? Probably. But what he did do, certainly, is he decreased the volume of space in that root canal system and maybe entombed some tissue and entombed some bacteria, and this resulted in a successful case. So, anyone can fulfill the principles of endodontics. Anyone can fulfill the principles of endodontics. What you have to have is knowledge about what you are trying to accomplish, and then try and accomplish it in an innovative way. And one innovative way I've told you is, once you've done your cleaning and shaping, take a pre-curved instrument and scrape the buccal and lingual walls just to put this debris in suspension so your irrigants can remove it. And with knowledge and some innovations, you develop the skills that are necessary to fulfill the principles of endodontics, and this leads to growth in what you're doing. This is a case that I did in graduate school. And if you look at your pre-op x-rays, you can tell there's 2 distal roots. You might get an idea that there's 2 separate mesial roots. And here's the fill x-ray. And indeed, that's what I found. And you can see that early in my career, and this one I was using vertical compaction of warm gutta percha, I over-enlarged the coronal portion. I say over-enlarged. It was necessary for this obturation technique. It's not necessary for other obturation techniques. At that point in my life, I thought vertical compaction of warm gutta percha was the best obturation technique. I no longer feel that way. Here's the last 2 cases that I did as a graduate student with vertical compaction of warm gutta percha. At this point in my life, I think that's removal of too much tooth structure to accomplish what you need to accomplish when you're doing a root canal. I came up with a technique of using thermophil, gutta percha around a central carrier. And here's a case that a general dentist had done, and it failed. Went to another endodontist, and the endodontist said, oh, this is too difficult to retreat. And he called me up and said, Ben, you developed this technique, you retreat it. Thermophil doesn't work. I said, well, send the patient over. And I was able to remove those carriers, reestablish my working length, re-prepare the canals, re-obturated using thermophil. It wasn't a failure of thermofill, it was a failure to fulfill the principles of endodontics. Removing the tissue, sterilizing the root canals, and obturating them to their terminus. Not only that, there were 4 canals in that tooth, and the clinician had missed the 4th canal. Now, this is an X-ray that was taken in 1919. Dr. M.L. Rhine doing a root canal with a chloroperca technique. And you can see that he didn't use very much instrumentation, but look at all the different apical ramifications that he was able to obturate. That technique has fallen out of favor. Silver points have fallen out of favor. But this is a silver point done by Dr. Bob Dewberry in Dallas, Texas. And Bob does a wonderful job of preparing root canals, does these silver point twist-offs, sealer under pressure behind it, and if there is a void, this sealer fills it. Here you can see that he's even filling an accessory canal. So silver points can produce three-dimensional obturations. Now, this particular patient I treated in 3 different decades of my practice career. One of them is obturated with lateral condensation. One is obturated with vertical compaction of warm gutta percha. And one is obturated with thermofill. You can't tell the difference. The patient can't tell the difference. And more importantly, the patient's periapical tissues can't tell the difference. All 3 were successful. Obturation merely maintains the healthy environment that you have created. Probably more important than obturation is actually coronal seal. You have got to get a good coronal restoration on these teeth as soon as possible. Now, endodontics is many treatment modalities. You may think of it as just putting on a rubber dam, and if you don't use a rubber dam, start using a rubber dam, because asepsis is very important in endodontic treatment. The only reason they fail is bacteria. You don't want saliva and bacteria getting into the area that you're working in. But endodontics is more complicated, and there are many different treatment modalities other than just doing a root canal. Here's a young boy. He was about 19 years of age, lower incisor, was discolored. I met him in a men's restroom, standing at a urinal. He had long blonde hair, and he said, "Hey doc, have you seen my yellow Camaro out front?" I said, "No, I haven't seen it." "Oh doc, it's beautiful. It runs great." And he introduced himself to me, and his name was Todd. I even remember his name. And I said, "Todd, have you ever had a root canal?" He said, "No, I haven't, Dr. Johnson." "Why?" And I said, "That lower tooth is discolored." I said, "Yeah, it's been that way ever since I got hit in the mouth." I said, "Todd, come into my office, I'll take an x-ray, see if you need a root canal." Well, you can see this huge lesion, and only this tooth was necrotic. So we did a root canal on it, and 6 months later, I saw Todd in the bathroom again, because he was a delivery boy to some other dentist in the office, delivery for a laboratory. And I had already bleached the tooth, so the coloration was good, and I happened to look at it. The tooth was no longer out of alignment. And I said, "Todd, who straightened your tooth for you?" He said, "Doc, you did." I said, "What do you mean I did?" He said, "After you did the root canal, that tooth just straightened up." So, endodontics can produce orthodontic movement if you heal the lesion. Now, I don't think that you should treat your orthodontic patients by doing root canals unless they have big lesions at the apices. But just by healing the lesion, the tooth straightened up. Now, this patient was referred to me for an apicoectomy. And when you look at this x-ray, you can see the lesion, and you can see that this doesn't look really good. And the tooth was mobile, and since she was referred to me for an apicoectomy, I was going to do an apicoectomy. But lower incisor teeth, the apices are very close together. And if you're not very careful doing a surgery on a lower anterior tooth, you can devitalize an adjacent one. All it takes is just a slip of the burr. So routinely, before I do apicoectomies on lower anterior teeth, I test for vitality on all of these teeth, so that eventually, if something doesn't work right, then I can test again and see if I caused it. Now, interestingly enough, if you look at this lesion, if you look very critically, you can follow it around like this. And when I pulp tested the tooth, this tooth was necrotic. Not only that, when I tapped on it, it was a little bit tender and it was slightly mobile. So I told this lady, I said, well, you were scheduled here for an apicoectomy on this tooth, but this tooth is non-vital, and I think we should first do a root canal on this, and then we'll bring you back to do surgery if surgery is necessary. So I did endodontic treatment on this tooth, and she came back 6 months later. Everything healed. You see no lesion. This tooth is not mobile. This tooth is not mobile. None of these teeth are tender to percussion. This, whoops, press the wrong button. This root canal had been in the mouth for 25 years. There's no lesion present. I am not going to go in and do an apicoectomy to make the x-ray look better, because the bone healing is excellent. So it was a diagnostic dilemma. We never did the apicoectomy, but we solved the problem. Here's another tooth that you could take a perio probe and just go to the apex. Are you going to extract it? Well, the patient didn't want to extract it. We opened up into the tooth. It was non-vital. We did a root canal. This is when I was doing lateral condensation, and you can notice a little accessory canal here obturated, and you can notice my working length is perfectly acceptable here. And the patient didn't come back for a checkup x-ray for 10 years. She came back for a checkup x-ray because the dentist noticed this root was resorbing. I also noticed this tooth now needs a root canal. The patient is 82 years old. She's perfectly comfortable. I had this amount of root resorption in 10 years. I don't know why, but I'm happy with the bone healing. Are you happy? I'm happy. She was happy. She said, Dr. Johnson, what do I do about this root resorption? Because that's what the dentist wanted me to answer. I said, I don't know, ma'am, but we did the root canal when you're 72. You're comfortable. The bone looks okay. You're now 82 years old. The way I calculate this, you can live to be 120 without a problem. So it's not ideal, because we as technicians want to do something to stop whatever process there is. I don't know what I'd do. I don't know what I'd do different, do better, but at that age, I'm not going to do anything. I told her she needed a root canal here. She said, I'm perfectly comfortable. I said, here's my business card. If you ever have discomfort, call me. Because if the tooth is more important to me than it is to the patient, then something is wrong. I don't recall if we ever did that root canal or not. Here's an 80-something-year-old gentleman who was referred to me for a root canal. This is my preoperative x-ray, and you can see it looks like a perio problem here. One important thing when you're doing preoperative x-rays is take the partial denture out of the mouth. I know he has a partial denture because of this metal cast. Here's a clasp coming around the tooth. I looked on the other side of the mouth. It was a free end saddle. And every time he bit down, it rocked this tooth. If you saw this radiographic appearance on a teenager, 13 or 14 years of age, you'd see the same thing around the apices of their teeth. I tested it with cold. It was vital. I told him to go back to his dentist and have his denture relined. There was no probable pocket. He went back to his dentist and had the denture relined. 1 year later, the dentist told me the bony architecture went back to a normal appearance. So this looks like an endodontic problem, but it's not. It's what you would see in orthodontic movement, and every time this gentleman bit on the other side, it was moving this tooth. So endodontics can be a diagnostic dilemma. Here's a tooth that was exceedingly long, seems calcified, perio communication with the distal root. Here are my working distance x-rays. You can tell I'm a little overextended here, and you know by now that doesn't bother me. I did as good a job of cleaning and shaping these canals as I could, and you can see these are size 20 thermofill devices, and even though I couldn't clean around this curve, I was able to obturate around this curve. Is that good? I don't think so. But is it better than nothing? Yes, it's better than nothing. Here it is, a year later, the periodontal pocket has healed up. Everything is very, very healthy. Here's another one, perio probe to the apex. And we know that perio-endo situations can heal nicely. Accessory canal here, a little overfilling, but it healed beautifully. Here's an upper lateral incisor. And that particular week that I saw this patient, the Journal of Endodontics came, and on the front cover of the Journal of Endodontics was an upper lateral incisor that had 2 canals all the way to the apex. I read that article and I said, "Phew, boy, am I glad I've never seen one of those." I saw 2 in 1 week after I read that. And here's one of them. There are your 2 working length x-rays. There are your 2 obturations, separate canals, and an upper lateral incisor. What did I learn from this experience? Quit reading your journals. Because if you read your journals, you're going to find things you never found before. And it complicates your practice. Now, of course, I'm joking when I say that, but there it is. Here's an upper lateral incisor. What's the longest tooth you've ever treated? 30 millimeters? 31? This one is 42 millimeters long. And the little lady stood about this tall and weighed about 90 pounds. Now, granted, she looked a lot like a baboon because her maxilla was huge. Do you know how long gutta-percha points are? 28 millimeters. This is a 42 millimeter tooth. Do you know how I treated this lady? I bought a set of veterinary endodontic instruments because they're 50 millimeters long. I didn't tell her that, but that's the way I treated it. And I used hand instrumentation, prepared the canals, and I used a silver point twist-off technique because silver points are exceedingly long. I fit it, I notched it, put my sealer in the canal, placed my silver points, and then put sealer under pressure. And when I say under pressure, you fill the whole canal with sealer, take a cotton pellet in the orifice, and push. It's like a piston effect. I had it well obturated because you don't see sealer coming past it. Here's a 1-year checkup x-ray. Worked fine. This is not the tooth. This is the tooth. Upper bicuspid, bayonet-shaped canals, 29 millimeters long, very, very long, curvy canals. And I use chloroperca to obturate it. And here you see some accessory canals. Chloroperca can be successful. Here's about a 6-year follow-up. Now, chloroperca is not popular now because we think chloroform evaporates and you can have a lot of shrinkage. The key to that is when you're using chloroperca, keep placing accessory cones and condensing as the chloroform evaporates, and you won't have that large amount of shrinkage. Some people prefer paste fills. That's okay with me. I didn't do this one, but it was referred to me by the dentist who did it, and he wanted me to do surgery. I said, no, we're not going to do surgery. We're going to let Mother Nature take care of this. And sure enough, it healed up nicely. Here's an upper central incisor, and somebody asked me about the use of calcium hydroxide earlier, and this is a tooth that's very applicable. Huge lesion. Here's my size 140 file. It's just rattling around in there. And you can, of course, see some apical resorption. I didn't know if this was external or internal, but it felt like I could feel tooth structure everywhere. So I filled this canal with calcium hydroxide, and then she came back about 9 months later, and you can see the lesion has healed. This gives me something, and when I put my files in, I could feel hard tissue there. I don't know if it was cementum. I don't know if it was cementum-like. I don't know if it was bone. I don't care. And I was taught to custom roll gutta-percha points. This is an exercise that is futile. Don't ever attempt. What I did was irrigate out the sodium hypochlorite. I dried the canal. I put sealer in the canal, and I took 140 gutta-percha point and turned it upside down. Warmed it in a flame and inserted it with apical pressure, and took an impression of the apex, warmed the gutta-percha, and kept condensing it and obturated it like this, and she still had the tooth 10 years later. This is a technique for treating a very difficult clinical situation. A lot of people would have gone back and done surgery or something like that. Not necessary. Treat it with calcium hydroxide until the lesion heals. This gives you something to pack with. And of course now we have what I call gutta guns. You've got the Obtura gutta gun. Dentsply has one called Calamus, where you can actually squirt in the warmed gutta-percha and condense it, which would be much easier than what I did at this point in time. Here's another case. A lady had a partial denture, free end saddle on the other side, a broken instrument coming out the apex, periodontal problem back here, lesion there. Now, as an endodontist, I would want to retreat this, but this was in the late 70s and I didn't have a microscope, and there's no way I could get that out of the root canal. Surgery was not an option, because by the time I did surgery on this, the roots were so short that she would have not had enough crown root ratio in bone to be successful. So I did an intentional replant. I extracted the tooth, cut this area off, put fillings in the ends of the roots, put it back in the mouth, put her denture back in, or partial denture back in, and told her to keep her mouth shut. And her husband said, "Oh, thank you, doctor, for telling her that." Now, this stabilized the tooth. You want them to use a soft bristle toothbrush, brush up on the gum, keep the area clean, and here it is, 10 years, no, that's immediate post-op. Here it is 10 years later. She has actually gotten a bone increase on the distal root. Everything is healed nicely. The little lesion over here has disappeared, and I think that was just because of movement of the partial denture. So intentional replants can work. Here's another intentional replant. Huge lesion. As an endodontist, I'd prefer to take this root canal filling out and re-instrument to the apex and re-obturate. But whoever did this case obviously has over-instrumented on the mesial canals, probably has ledged them dramatically, and the chance of me getting in here is minimal. So my two choices are surgery or intentional replant. I never decide for a patient what they should have done. But I will tell you that going through 3/4 of an inch of cortical bone on a lower second molar to do an apicoectomy is not fun. So I told her, Mrs. So-and-so, I can do surgery. And when I do surgery, I take a knife and I slit your gums. I tear the gum away from the bone. I chop a hole through the bone, hack off the end of the root and put a filling in it, and then I sew you up. Or I can delicately remove the tooth, put fillings in the ends of the roots, replace it in the mouth. All you have to do is kind of keep your mouth closed for a couple of weeks and brush up with a toothbrush. What do you think she chose to do? She chose the intentional replant. If I wanted her to choose surgery, I'd say, ma'am, we can make a delicate incision here, reflect the tissue, place fillings in the end of the root, and suture you back up. It's not painful. Or I can jerk the tooth out of your mouth, hack off the ends of the roots, put filling in it, and stuff it back in, and if you don't lose it, it might work. Now, if I say it that way, they're going to choose surgery. But the patient made the choice. She chose intentional replant. Here it is, post-op. Here it is, 15 years later. Intentional replants work predictably if the patients are over 25 years of age. Under 25 years of age, don't stand a chance. And I suspect this is because of the antigen-antibody effect. They just reject these teeth. They start resorbing. But over 25 years of age, very predictable. Here's a woman that lives in Tulsa, but in the winters she goes down to Mexico because the weather is better. And she has her dentistry done there because the fees are cheaper. And the dentist in Mexico did this bridge for her, and then she had problems with it. So he went in to do a root canal, and he drilled down through here, and he perforated on the mesial buccal aspect of this bridge. That's not such a terrible thing to do. It happens to people. But what was terrible is he filled this perforation with a mixture of zinc oxide and eugenol and formocreosol. And she had a lot of swelling, came back to Tulsa to see her dentist. He sent her over to me, and when I took her lip and pulled it out to look at it, the gingiva and the buccal plate of bone came with the lip. And I'm looking at this huge, angry defect. And she said, Dr. Johnson, I don't want to lose this tooth as part of this bridge, and I just had this bridge placed 3 months ago. So I told her what I was going to try and do is remove this bridge, tap this bridge off, and then I was going to go down in through there, remove all this tissue, find the root canal, do the root canal, repair this perforation. But ma'am, with all of this bone loss and this tissue, I'm not at all sure this will work. She wanted me to try. So when I tapped off this bridge, lo and behold, this root came out with a bridge. This is not good. So I took my gloved fingers, pulled the root out of the bridge. I'm holding it in my hand. I do the root canal. I seal the perforation with alloy. When I did the root canal, some sealer squirted out of here. There's another accessory canal. I filled that. And then I did an apicoectomy, filled that. I cleaned the cement out of the bridge, put the tooth back in the socket, put more clean cement in the abutment areas, re-cemented the bridge. It is in the mouth. I don't give this tooth a chance, a snowball's chance in hell. This tooth will not work. Here's this tooth 10 years later. And the tissue reattached to the tooth. There is no probable pocket. Endodontics can be heroic treatment. Heroic treatment occasionally works. These are silver points. Why this one worked, I don't know, but it's been in the mouth for 20-something years. Here's one When I went in to retreat this, 9 silver points came out of this distal canal. I asked her, I said, where did you have this root canal done? She said, Memphis, Tennessee. I said, did Dr. Siskin do it? And she said, yes, Dr. Siskin, Milt Siskin. Milt Siskin believed in laterally condensing silver points. He would put the silver points in mercury and soak them, thinking that that would soften them, kind of like mixing up your amalgam alloys. And then he would laterally condense them. The problem wasn't the apical seal. The problem was he fractured this root. The tooth had to be removed. But lateral condensation of silver points is no longer being practiced. Paste fills. I don't consider that even endodontic treatment. So we won't even discuss that. If you're going to do paste fills, I don't care. Go ahead and do complete cleaning and shaping of the root canals. Don't do that. There's an endodontist in Oklahoma who believes that the minimum apical size on the smallest canal should be a 45. The minimum size for a distal root of a lower molar or the palatal root of an upper molar should be minimum 60. The minimum size for the apex of an anterior tooth should be a 90. I don't believe in minimum sizes. I don't believe in destroying tooth structure with Gates-Glidden drills. I don't believe in this sort of endodontics. Was it successful? Yes. Did the general dentist have much to work with once the root canal was done? No. We're getting away from this type of preparation. We're going to more conservative preparations, and you saw this tooth earlier today. I don't like the excess filling material any more than you do. This is certainly more palatable than that, but I would still like to see less than that. And here it is from another view, and here's a 6-month checkup showing everything healing nicely. Minimum removal of tooth structure. These are x-rays from my last 10 years of clinical practice. Again, you can see I don't worry about the working length x-ray going through the terminus of the canal, because I know with periapical disturbance, your success in root canals increases. And here are my preparations, tapering funnel form preparations from orifice to apex, creating good convenience form for my irrigants, even better convenience form for my irrigation in a year or so, whenever that other technique comes on the market. I think that's beautiful. Here's another one, minimum enlargement in the coronal area. Something like this you certainly don't want to open too much, because this is a very skinny mesiobuccal root, and if you opened it too wide you would perforate. And here's mid-root curvature that is pretty severe. Not only that, it has 2 canals in the root, and you see it's a very thin root. Don't over-prepare these thin-rooted teeth. They can be handled with minimal preparation, maximal care. That's it. I thank you for your attention. Particularly thank you, Estuardo, for inviting me here. It's wonderful to see friends again and to visit places. I hope that I have given you an idea of what industry can make for you and can provide you for your clinical endodontics. And just like I said earlier, I'm not as handsome as Tom Cruise right now, but I'm getting better. And I want you to know that the endodontics that you choose to do, if you have good skills and you apply the principles that I've outlined today, you'll have good success. And in the coming years, you're going to have even better success. Thank you. Thank you. Are there any questions about what I've said today at this point in time? I don't know that I have the answer, but I will try. Yes?
What is the protocol that you use when you do a retreatment?
What's the protocol I use when I do a retreatment? The protocol that I use when I do a retreatment is, number one, to try and remove the root canal filling to the best of my ability, whatever that is. And And if it's gutta percha, principally the technique that I use, I look at the pre-op x-ray and I estimate the size of the apical extent of the filling material. And then I look how much flare the canal has to it. I select a profile rotary nickel titanium instrument that is one size smaller than what I think the obturation is. And if there's not much flare, I make that a profile 04 taper. If there's a lot of flare, I make it a profile 06 taper. And I get a contrangle, a different contrangle that will give me a greater speed and still maintain torque. I want the speed to be a minimum of 1200 RPM, a maximum of 2000 RPM. I open up into the tooth, remove the restorations from the floor of the chamber, expose the gutta percha, and I start the handpiece running at this speed, and I put it on the gutta percha with minimum pressure. And I put it in, consider this to be the instrument, I put it in, press just a little bit, kind of enrolling it around, press just a little more, and you'll see it start to melt the gutta percha. And as it starts to melt the gutta percha, this instrument will go down in the canal. And what happens, these radial lands on the profile, it'll melt the gutta percha, and as you're moving apically, by the time you get down 3, 4, 5 millimeters, it will start to exert an extracting force on the gutta percha because it is binding against the canal wall and the gutta percha point at the same time it's softening the gutta percha, and that tip, being rather small, will catch the gutta percha, pull it up and out. Once it's up and out of the root canal, then it's a matter of re-cleaning and reshaping the root canal. Now, on retreatments that have failed, the principal bacteria that has been associated with failing root canals is E. faecalis. Now, there are others, but E. faecalis is very difficult to kill. Calcium hydroxide doesn't do it very well. Iodide, potassium iodide, better, but keep in mind that the dentin, everything in the tooth, pretty much inactivates iodide, potassium iodide. A recent medicament that is available is called BioPure. It's the MTAD that we talked about earlier today. It's very effective against E. faecalis. So once I get the canal re-prepared the way I want, and generally I will prepare through the terminus just a little bit, half a millimeter, and I will use this medicament to remove smear layer and to eliminate E. faecalis, irrigate again with sodium hypochlorite, dry the canals, and then obturate. I do them in one visit. I don't do them in 2 visits. That's how I do it. Any other questions? Well, if there are no questions, you are dismissed for happy hour, drinks, beer, whatever. Thank you very much.
Well, Ben, thank you very much for being here. We really appreciate your time. I know that you are a very busy man and you need to be in Bulgaria next Sunday.
Yeah, Sunday.
Just keep rolling, and thank you very much. We appreciate that. As I told you this morning for the audience here, you are both academic, scientific, and a clinician mainly, and that's what has been magnificent for all of us that do endo every day, because you have made our life much easier doing our daily work. We appreciate that much, and we want to present this certificate of appreciation that say Universidad Francisco Marroquín present you with this recognition for your contribution in our 25th anniversary lectures. Thank you very much.
Thank you. Appreciate it.
Thank you very much.
Thank you.
Okay.
Thank you.